Ms Carey.
May Professor Jean White be sworn, please?
I swear by Almighty God that the evidence I shall give shall be the truth, the whole truth, and nothing but the truth.
I hope we haven't kept you waiting too long. I appreciate you were here this morning, probably. Yeah, I'm so sorry.
It's okay.
Professor, your full name, please.
Jean Christine White.
You were the Chief Nursing Officer in Wales, I think, from October 2010 to retirement on the 6th of April 2021.
That's correct.
And your statement is at INQ 480133. I hope you have it in front of you.
Yes.
And just to explain, the statement was in fact written by you and indeed your successor CNOs. I'm obviously just going to be asking mainly about your role, but it means we will have to cover a number of pages, as obviously some of the statement deals with them. Your professional background, please. Could you just give us a summary?
So I'm a registered general nurse, a registered nurse teacher. I have postgraduate qualifications up to PhD level.
When did you become a nurse, if it's not too rude?
I was born and brought up on the Gower Peninsula, and I trained in Swansea University, at Swansea Hospital as it was then.
You know that we have just heard this morning from the Chief Nursing Officer in England during the relevant period. Can you just help us in relation to the CNO Wales's role? Is there any substantial difference in functions you had that differed from those in England?
So the CNO role in Wales is a substantive civil service role, whereas it's an NHS role in England. I think that's the largest difference. So my advice was, my role was to give advice to Welsh Government ministers and support policy delivery.
All right. And I think you are the head of the nursing and midwifery professions in Wales with about 40,000 practitioners or thereabouts at
That's correct.
the time. All right. I think you are responsible for the performance of nurse directors in each of the health boards and trusts in Wales.
That's correct.
Right. And I think you say in your statement, if I may take you to it, at paragraph 62 onwards, you said you didn't have a specific role in respect of public health emergencies.
That's correct.
Do you think that the Chief Nursing Officer should be involved in planning for public health emergencies?
So from my experience in this current pandemic, I would say yes, particularly not for infection management processes, but more around the workforce implications, some of the consequentials really about how nursing and midwifery practice is affected during a pandemic.
Have you raised with anyone more senior than you the fact that you think the CNO would have a vital role to play?
No, I didn't before I retired, but I can see in the statement that the current CNO is of a shared view, that's Sue Tranker, and I would expect her to be part of the post-COVID preparation for the next pandemic.
Your particular role during the pandemic, are you able to give us an overview of how that role and your responsibilities changed during the relevant period?
So some things were built on the pre-pandemic period. So, for example, I had to performance manage and support the executive nurse directors. So I did more of that, and they were sort of key partners in the collective leadership we had to deliver services in Wales. But there were particular new responsibilities that came. For example, I jointly chaired the Nosocomial transmission group with the deputy CMO, which I'm sure you'll come on to in a little while. And there are things to do with changing the way that the nurse education, midwifery education standards were changed by the regulator. So all of the CNOs across the UK were involved in that. So that's an unusual thing for us to do. We didn't normally get that close to changes of the regulator's work.
I think you were also a member of the NHS Planning and Response Cell in Wales,
Yes.
which was established towards the end of February of 2020. In a nutshell, what did the Planning and Response Cell do?
So this was chaired by the Director of Planning, so I was a member of it rather than the leader of it. And that cell brought together folk from the NHS services to work out how we could plan and deliver services during the pandemic, the sorts of things that would affect how the NHS functioned. So we were planning for closures or reopening, anything to do with the operational delivery of services in Wales was worked out there and then advised on, if you like.
Can I just ask about your role in the pandemic? We heard from Dame Ruth that she was able to take a number of visits and did ward rounds. Did you perform a similar function during the pandemic?
Unfortunately, I wasn't able to go out and meet people face to face. I have rheumatoid arthritis and therefore have immunosuppressant therapy, which makes me clinically vulnerable. Not a shielded person, but it did require me to work remotely, and that was enabled. Fortunately, we had good IT, so I was able to talk to the people I needed to talk to and was always accessible, but I couldn't physically go and see for myself, which is, I think, was a great shame. I would have liked to have actually talked to people about what it was like to be there and do the role under those extreme circumstances. Obviously, you'd have to be careful with that because you don't want to be one of the agents carrying disease from place to place. So I'm not suggesting I would have done a round Wales tour if I would have been able to, but I certainly would like to have had more of a chance to talk to people face to face, which was a shame, but there you are.
How was the frontline impact on nurses and midwives then conveyed to you, given that you couldn't, for the reasons you set out, go to wards and hospitals?
So I have a series of clinical networks that predated the pandemic, as well as relationships with the trade union senior officials. So I used the existing frameworks. We have clinical groups on various things. And I had close working relationship, as I said previously, with the executive nurse directors. And I relied on them to tell me what it was like. Occasionally, I would have correspondence between folk that would also tell me what was going on. If they had a particular issue, then I would be able to respond to it. And there were members of nurses, nursing and midwifery workforce on the various cells that I sat on. So whether it was the planning cell or the Nosocomial transmission group, there were also representatives on it. So I had lots of contact with people. It just wasn't seeing for myself and feeling what it was like on the ground. I knew from those conversations that it was very scary. And as a clinically vulnerable person, I have to say that really resonated with me about fear. Beginning of the pandemic, without a vaccine, the testing was limited, not knowing really what was going to happen to folk. I really felt for everybody affected because I felt it myself, and it restricted my life a lot because of it, like a lot of other people.
Can you give us an overview of what was the state of the nursing and midwifery profession in Wales pre-pandemic in terms of vacancies?
So obviously vacancies change almost every day because people leave and they join and so on. We weren't in the same position as England. We didn't have the volume of vacancies, but I'm not suggesting that it was 100%. So there were vacancies in various bits of the health service in Wales. And we had lots of activity to continue to both recruit and retain staff. It's the retention often is the issue rather than the amount of people you're training. So, for example, I was one difference from the rest of, from England, for example. We required, if anybody had a student bursary package, I think you heard about bursaries earlier, if they received that support from Welsh Government, they were then required to work in NHS Wales for 2 years on qualifying. And if they chose not to, they had to pay back the money that we'd given them. So it was kind of golden handcuffs kind of approach to keep the staff we trained.
You speak, as I do, very quickly.
Yeah. Oh, I'm sorry.
Don't worry, I want to head off any complaints.
Okay, I'll slow down.
It's my fault. Let me slow down as well. Can I call up on screen 480133? Page 58, please. I'm going to check I've got the right reference for a start, but I want to ask you, Professor, about some of the efforts made to increase capacity within the nursing workforce. We heard this morning there were four main ways that was aimed to achieve that. One of which was, of course, to invite people onto the temporary register. And I just want to look at it from the Welsh position, if I may. And if that's page 58, I hope it sets out the position as of the 21st of April 2020. We looked at it this morning in relation to England, but we should see, I hope, Wales, yes, there. Registrants, there were 537. Just pause, please. It's just at the top of our screen there. Nurses, as at the 21st of April, that joined the register. Can you help with how many of those actually got to work on the front line?
So I don't know accurate numbers, but I certainly heard sufficient evidence that quite a number of folk didn't end up practicing in the way they wanted to. And that was multifactorial. Some people, when they'd done a risk assessment, realised that they were at higher risk, and therefore we couldn't deploy them to places that we would have wanted them to do. So a lot of folk would say, well, I can't travel to that place, or I don't feel confident to work in that place. So there was a degree of choice amongst the folk that kindly and bravely put themselves forward to come back on the register. We tried our very best to place them. We developed a central system to help with that ran during 2020, which supplemented what the local recruitment arrangements were doing. But it would be fair to say that not everybody that put themselves forward ended up working for us.
But the numbers of which you're not?
I don't know that number off the top of my head for that particular month in time, sorry.
Initially, the temporary register was opened up to those who'd been practising in the last 3 years and then expanded to 4 to 5. Were you ever made aware of any concerns about the length of time people had been off the register for, coming back and working, and perhaps not having the skill set that they had as at the time they left the register?
Yeah, so anybody who'd left the register and was brought back into employment, we're giving an induction programme, and we're given sort of reminders, if you like, about how infusion technology worked, about moving and handling, those sort of basic things. For the staff that had been away a long time or had been working in roles that were not clinical, because some academics would come back to practice, they needed more support, and were always supervised by colleagues if they were not feeling competent. It was part of the safety arrangements. I wasn't told specifically about that age group, that length of time, if you like, being away from the register, but all of them needed support. So I wouldn't necessarily pick them out as needing or being a problem, shall we say.
Okay. Was that support provided, though, by fellow nurses and midwives?
It was supported by Health Education Improvement Wales, which is a body we have in Wales, my lady, who do things on behalf of the government to support the workforce. So that's everything from commissioning education to doing things to develop the workforce and support the workforce. So we asked them to work with the local health boards, who are the employers of the staff in Wales, to make sure that they had the stuff they needed. But most of this was delivered on the ground with respect of who was being brought forward to enable them to get into jobs as an on-site induction programme.
I suppose really what I was asking was, if you bring them back, they're designed to help relieve the burden, but is there not a burden in training them, making sure they're up to speed, as it were, on the skill set? I was trying to work out who that burden fell on.
Well, it would be sort of the health boards, the employer body, in the majority supported by others. I suppose it's a payoff, isn't it? You're going to end up with hundreds more staff, but you're going to have to invest a little bit to make sure that they're safe and competent to work. So it was unavoidable, I'm afraid.
Can I turn to nurse staffing levels,
Yes,
please? And I think there is an act in Wales, the Nurse Staffing Levels Wales Act 2016, which
yes.
imposes a number of duties and obligations on the health boards and trusts. And if I may, without a legal lecture, are you able to summarise what the Act says and its import?
The Act brings in a range of duties. The first duty that across the health system in Wales, every organisation must have a duty to see they've got enough nursing staff to sensitively care for patients in all settings. The second duty is to say that in specific service areas, that is adult, medical and adult surgical wards, they must use a defined methodology of working out how many staff they need to sensitively care for the patients in that ward. During my time as CNO, we extended the law so it now covers paediatric inpatients, but it didn't exist in my time there, but it does exist now. The Act goes on then to say how often you need to report, and it has to be reported to Welsh Government every 3 years.
So if I understand it correctly, the Act doesn't stipulate it must be one-to-one care in this, but it tells the boards that they have to have a process or a methodology, to use your word, to be able to monitor their ratios.
That's right.
Is that it in a nutshell?
In a nutshell, and this methodology is determined by government, so they can't just make it up themselves.
Understood. Can I ask you about the ratios in intensive care, please, and the changes that were brought about during the pandemic? If it helps you, Professor, I'm at paragraph 191 in your statement, and maybe we will look at some documents that were shown this morning. But do I take it that in non-pandemic times, it should be one critical care nurse per one level 3, i.e. a patient that's being on a ventilator, for example? Is that the general rule?
Yes.
Ratios were stretched or diluted, were they not, in Wales as well during the pandemic?
Yes.
Who was responsible for making the decision to change the nurse-to-patient ratios?
So Wales required its service to double the capacity. So we needed to, if you like, double the capacity of critical care nurses that they were covering, the patients they were covering. And so we have a critical care network that supports all of critical care services across Wales. And it was Welsh Government advice to them to consider the national guidance that had been shared with us about what might be sensible to do. And they then looked to see how that could be delivered within our NHS. So it was a process of a UK collaborative of expert groups coming together to say, this is what we think might work. And that then being given to us as Welsh policy leads to translate that into what could happen within our NHS systems in Wales, given that we wanted to increase the number of critical care beds by 100%, so there's like 200% of what we used to have.
So it wasn't your responsibility as CNO. Who was it? The Health and Social Services group that made the ultimate decision?
So I gave professional advice into the policy leads, and then they worked with the network. So they followed the advice that came from the UK collaborative, if you like. But the critical care network were the ones that had on-the-ground experience about what would work in practice, and they then challenged back. And the original guidance around dilution was quite extreme, to be honest. It was something like 1 up to 6.
Yeah.
And they were saying, whoa, that's much too far. And the furthest we ever went was 1 to 3, and that was only in extraordinary circumstance. So we never went further than that. And that's because the critical care network were giving a pushback, if you like, about what was being suggested by these professional advisory groups.
Yeah, I think you said it was 1 to 2 or occasionally 1 to 3. Right. Who was responsible for monitoring the ratios?
Well, the health boards all have responsibility of delivering the services to meet the needs of their patients. The the critical care network across Wales, the trauma and critical care network, support them and helped have mutual arrangements. So I'm happy to say we never ran out of a critical care bed in Wales. Anybody who needed level 3 care got level 3 care. There was never a moment when there wasn't a bed available. But it may not necessarily be the local bed available. It might be in the next hospital, in the next health board area. And the network helped make the movements around because they knew what vacancies there were. So it was much a collaborative approach across the whole system rather than individual hospitals trying to cope.
So there may have been the bed available and staff available, albeit at a diluted ratio. I wanted to ask you, though, do you think that that dilution impacted the level of care that patients got in Wales?
I would say it added to the stress on the staff, all of the staff, because it wasn't just the nurses, obviously. We had more patients, therefore the medical staff and so on were also impacted. Like other parts of the UK, we developed supplementary teams that would support them. So we'd have turning teams, for example, that had
literally
turn patients for this an approach called proning. It was found that those were very ill. If they did well, if they were also put face down, and that takes about 6 people to do that. So we recognised that the critical care nurses would be under tremendous pressure. So we tried to bring in things that would support that. But to be honest, I suppose if you're looking after twice the number of patients, it's going to be difficult.
Yeah. I follow bringing in someone who can physically help turn the patient or prone them. What about actual support for them, though, dealing with the stresses now of dealing either with 2 critical patients or 3 critical patients day in, day out? Did you as CNO do anything to try and help them in a sort of more pastoral context?
So I met with the executive nurse directors from about the middle of March onwards. I think it's from about the 18th of March onwards, twice a week. And throughout the first wave, certainly the welfare of staff and the concerns about critical care staff and the pressures they were under were part of our conversation. Obviously, the health boards have responsibility for the welfare of the staff as their employer. They have a duty of care. What we did was we supplemented that local support that was being offered by a national offer as well of resources. And that was facilitated by Health Education Improvement Wales. Remember I said there was a body that helped with the workforce. And so we have had contracts to do with Samaritans. We extended a programme called Health for Health Professionals, which is an approach that was pre-existed pandemic, which was for doctors only, but we extended it for all staff and students during the pandemic, which is where if you rang up and said, I'm in need, I'm in distress, you would be assessed by a doctor and then a programme would be worked out for you. Some of it would be one-to-one guidance and so on. And then we had lots of programmes like Silver Cloud, which was online mental health stuff. It wasn't specifically for critical care. There was a doctor...
Can I pause you there? Because I
Yes,
want to just look at one very specific issue in Wales. And I'm sorry to have interrupted you, Professor, but can I ask, please, that you look behind tab 9 and we call up on screen 412539 and actually start at the back of that document on page 0005. Because clearly there was pressures at the beginning of the pandemic, but I want to ask you about an email chain that is from January 2021. And to put it in context, Andrew Goodall, who was, I think was the chief executive at the time of the Health and Social Services Group.
Yes, that's right.
He sent round to a number of people a newspaper article talking about the dilution in England, which then prompted a discussion about the position in Wales, just for the context. And if we go to page 3, having skimmed through the article, I think he was asking you what was going on in Wales, and you say at the bottom, is there anything I should be saying back to Andrew, re-dilution of staff in our units? Can you give me a summary position? and then up to the email above. So here we are, 12th of January 2021. And you are addressed, sorry for the delay in replying on Monday, for example. 11 of the 13 IC units were on a stretched nursing ratios, 1:2 for level 3 patients. Redeployed staff have been moved to critical care to help out these units. However, given the hospital strain and vast number of patients in critical care, redeployment hasn't actually been 100% enough for all critical care patients units in Wales. Uncertainty around the impact of this on the quality of care and ultimately on the outcomes. I've raised staffing ratios in the critical care network meeting. They were of the opinion, particularly as in many units, there are not redeployed staff to support stretched 1:2 care. We should only further stretch this by exception.
Yes.
So by January 2021, is it fair to say that the stretch might be an understatement for the 11 of the 13 IC units across the nation?
Yes, it was very tough. During the second wave, to a degree, I suppose it was worse than the first wave because a lot of staff were needed because we were starting to reopen other bits of the hospital. So there weren't the availability of staff to redeploy. I think the network was very sensible in saying, look, we can't have sort of 1 to 3. That would be too dangerous because there aren't the supplementary staff to support them. So that's what this was all about. Because at that time we were having other guidance to say, you might still be able to do 1 to 3, but no further than that. I think that's what the UK guidance was kind of suggesting. And the network, as I said, with our sounding board about what was actually happening on the ground, was saying that wouldn't be safe to do that. And so we listened to that.
Slightly different topic, but still on ratios. I think in your statement at paragraph 257, there was a concern raised with you about ratios of registered nurses to patients in the field hospitals in Wales. Can you help? What were the ratios in the field hospitals and what was the concern?
So it wasn't necessarily that I was worried about the number of nurses. It was more how the makeup of the teams were being constructed. So field hospitals in Wales were not intensive care provision. They were actually step-down provision. So we wanted to increase the flow of patients out of hospital. So these were people that were taking some time to recover before returning home or needed to have some more support before returning to a care home, for example. So I discussed with the nurse directors, and this is what this document starts to talk about here, is how are we going to do this? What kinds of teams should we have? And the nurse directors were of an opinion, actually we should have occupational health nurses, mental health nurses, physiotherapists, rather than it all being nurses, registered nurses and nursing staff. We needed to have a more multidisciplinary team. And so the nurse directors themselves shared their practice, and as the field hospitals started to come live, if you like, in a sort of a phased approach across Wales, they learned from earlier experience to work out what would be best.
Different topic, please.
Okay.
The Nosocomial transmission group.
Okay.
And it starts in your statement at paragraph 316, but it was established, I think, on the 19th of May 2020. You jointly chaired it with a Deputy Chief Medical Officer in Wales. What was the purpose of the group, please?
So it had a number of functions. We were there as an advisory and oversight group to look at the evidence-based guidance that the system needed about giving advice on everything from how far apart hospital beds should be to handling how the deceased person's body should be managed. It was there to look at the education and skill set around IPC and try to support how the system was responding to hospital-acquired infection, which is what nosocomial transmission is about. Later on, after a few months, we took on a particular role in oversight of outbreaks because we were finding that the health boards, some of them were struggling to get on top of outbreaks of the infection. And so what we wanted to do is promote best practice and keep a closer eye on the system to help them deal with that. So we took on more of a role to do with outbreaks later on.
I think in your statement you give a number of examples of operational matters that the group became involved in, but I would like to ask you about one, please.
Sure.
If you look in your statement at page 121, it's in relation to the wearing of face masks in non-clinical settings. And can we just, we haven't heard very much about non-clinical settings yet, but what are they in a nutshell?
So if you like, it's the backroom arrangement. So that'll be your folk in offices, perhaps dealing with ordering kit. It could be anything where you're not actually looking after a patient, I suppose would be the simplest way of doing it.
Okay. Now, I think the position is that there was UK IPC guidance issued in due course by England, and I think it may have been Scotland as well.
That's right.
That said that face masks or face coverings should be worn in both clinical and in non-clinical areas. And when that came out in England and Scotland, in Wales decided not to make face masks mandatory in non-clinical settings. Have I got that right?
That's right.
All right. Now, why did Wales take the decision not to make face masks mandatory?
I was not the policy lead on this. I did take sort of the steer from the CMO who had given advice to government on this issue. So we had found that the evidence around face coverings and face masks in a sort of a community setting rather than a clinical, I'm not talking about the kind of delivery of care settings, was less robust than it was for clinical settings. And particularly concern had been expressed in the summertime about how people in the public were actually using face masks. It increased things like touching your face and not, it caused people to perhaps not follow some of the other guidance. It took more risky behaviours and so on and so forth. There's a long list that I've listed out in my statement. So the CMO was of the view that the evidence wasn't strong enough to require that. So we had taken the policy position in Wales that we'll do it where the evidence took us, which is in clinical areas. Now, I think in his evidence, he's gone on to say how that then...
Well, we'll hear from Mr. Atherton in due course. But can I just ask you this? Do you think, though, that by not making face masks mandatory in those areas, there was a lack of protection for those workers who were in the non-clinical areas?
I think hindsight's important here, because at the time we felt that if you kept distance and had good ventilation and had other sort of environmental factors in play, the risk was probably low. That's what the evidence was telling us at the time.
Pausing you there, Professor, is a non-clinical area likely to be well ventilated in most of the Welsh hospital estate?
Some of it, probably not so much. I couldn't hand on heart say everybody was able to open a window and so on and so forth. Some of our estate is very old in Wales.
Do you not think that the benefit of mask wearing outweighed the asserted downsides of people touching their mouths or touching the mask?
At the time, we didn't feel it did. I think as time went on, and I'm looking in hindsight now, not from what I felt at that moment, understanding about how the disease was spread would probably give different advice now if we were to go back in time. But at that moment in time, the evidence wasn't very strong about wearing face coverings unless you're in a high-risk area, which is direct patient care, enclosed, confined areas, in well-ventilated areas with other good IPC practices, the risk was less.
Sorry, I didn't interrupt you. In due course, though, did Wales make a face mask wearing mandatory in non-clinical areas?
They did.
Was it about 3 months or so after?
Yes, it was the autumn. I can't remember exactly the date.
And why did it change its stance come the autumn?
I think partly it was leading to confusion with the public because there were different messaging across the 4 parts of the UK. Our intelligence was growing about what was needed to prevent infection. I think that was it. But as I say, I wasn't the policy lead for this. I was in more of a supportive role. The chief medical officer was, if you like, the lead advisor on this. I don't have personal expertise in infection prevention and control measures. I'm not a scientist by background. So I needed to follow the advice I was being given rather than saying, no, I think I'll go UDI here and make my own advice.
I think in due course, certainly there's been some studies to suggest that infection rates went down when there was universal mask wearing. Although it won't be a decision taken by you in due course, do you think that had there been universal mask wearing throughout the hospital estate, that would have helped prevent infections of patients and indeed healthcare workers?
I'm sure it would have helped, but also the other practices were very important. Face mask wearing on its own would not stop the spread of disease. If people were not hand washing, were not keeping distance, and doing all the other things that we were advising. So I would say it's part of a package. It's not a panacea of stopping all infections, but it certainly has a part to play.
One of the other things that the Nosocomial transmission group did was set up what's called a sort of lessons learnt group. I think it was was it the early learning platform?
Yes, we called it CORSIL, which sounds like some sort of chemical you'd use, but it was the COVID early learning is what it was. It was a platform.
And what were the kind of things that were being reported via the early learning platform?
So this was set up so that anybody in any of the health boards across Wales and the trusts as well could say, look, I've done this thing, whatever it was, large or small, and it either worked or didn't work, and perhaps you shouldn't do it. So it could be anything from cohorting patients who have the disease when you've got lots of open plan areas to anything. It could have been anything at all. Throughout the pandemic, that was available to people to do that.
Do you think it was a useful reporting platform?
I think it was helpful. It had one particular limitation in that it was on a separate IT system to, we have lots of different IT systems, my lady, across the
I've got
service.
that T-shirt.
Yeah, you know exactly what I mean. So it meant that rather than it automatically sucking things and easily transferring information, you had to go out of your system into another system and then report it. And I think it put off a few people. So I think it was useful. I certainly would have it again, but probably on a system that is a little bit more joined up.
I just want to understand the genesis of a document I'm going to ask to be called up on screen, which is 473936, and we can go to 0001. I want to understand how this document was reported. It's a COVID outbreak reporting. Is this linked in any way to the early learning?
No.
No. That was my error then, thank you. Then can we nonetheless look at this document though, please? This is an example, is it not, of weekly reports that were submitted showing outbreaks and changes and the location of the outbreaks within Wales. Is that right?
That's right.
And here's one for the 11th of December 2020. Who is collating this information?
So a little bit of context, yes, if that would be all right. So outbreak management was previously managed by Public Health Wales pre-pandemic. But we were finding that the data had a delay in it. So you'd have a report of the outbreak that was last month. Well, when you're managing outbreaks, you needed it to know every day. So the Nosocomial Transmission Group developed a form that was required to be filled in by the operational manager in each hospital on a daily basis and sent in to the Public Health Wales and Welsh Government mailbox. And so this report is the data that was submitted by each of the health boards about what was happening. So that's the number of patients involved in any outbreak, the number of staff affected, and any patients that had died within 28 days of the outbreak. So it's showing us a direct impact on the patients of those outbreaks. So we needed to know exactly where they were happening, how quickly they were coming under control, and what the health boards were, actions they were taking. So they were also telling us what they were doing.
Just pause there and we'll just look at one example. Can we turn to page 5 in this document, please? And I think a submission, forgive my pronunciation, by the Health Board.
Yeah.
Thank you. But if we see what that health board submitted that day, and I presume all of those there are different hospitals.
Yes.
With the names of them, and you can see across the 4 sites there were 2 wards closed in Llanwilly. The position there in Prince Philip Hospital, they've had to transfer patients.
Yes.
We've got a ward closed in Withybush, and a slightly different position in the community hospital. And was this being done on a daily basis?
So the data was being reported to us on a daily basis, and we had sort of a weekly position, if you like, to see what was going on. But it was useful for both us as the government and Public Health Wales to look at what's happening across the whole system. But it was also useful to the managers in the hospital because they have the data was shared back to them, if you like. They could see what was happening. It also meant that if, say, Hywel Dda was struggling in Prince Philip Hospital, yet down the road another hospital was doing really well and very quickly getting under control, we were able to say to them, you need to talk to that manager to see what they're doing that you're not doing to learn from this. So this was a really transparent way for us to see what was going on, and a really good way to help the system learn, because people were obviously catching the disease in hospital when they were already ill and there because of another reason.
Well, I wanted to ask you about that, actually, because I think it's right that there was guidance issued that said that there should be testing for all patients admitted into hospitals in Wales, issued on the 3rd of June of 2020. And I'm in paragraph 324, if it helps you, Professor.
Yep.
So the guidance came in on the 3rd of June for testing of all patients, but was brought in Wales on the 15th of July. And can I ask you, why was there a gap between the guidance being issued at the beginning of June and then not coming in until 6 weeks later?
I think we gave them a run-in time to actually get the systems in place in order to do that consistently. Now, obviously, once the guidance is out there, there'll be early adopters, but some folk will take a little bit longer to get systems in place. So often we would give them a couple of weeks time lag to get to a position where everybody was doing it. It's a big system.
We heard this morning from Dame Ruth that she thought that the rollout of testing would have a big impact on the healthcare system's response, and indeed in particular on nurses and midwives, and visiting restrictions,
Yes.
For example. Do you agree with her as the importance of testing in the event of a pandemic?
Absolutely. If you want to try to enable a system to keep delivering other care, you need to separate out those folk who have got an infectious disease from those folk who don't, so that you're able to have, I hate to say sort of a clean system, but those are not affected. I don't know what language I should use here, which doesn't sound inappropriate, but you understand what I'm trying to say. If you want to run an orthopaedic service, you want to know those folk that have got it and who haven't got it. Because the last thing you want to do is bring somebody into the system that's then going to contaminate the system that they've gone into. So testing was very important, which is why it was a requirement.
Yeah, and am I right in thinking that testing of healthcare workers in Wales was not fully rolled out until March 2021? Is that right?
I believe so. I can't remember exactly the dates.
Do you think it should have been rolled out sooner for healthcare workers?
I think that the issue was more around asymptomatic testing and symptomatic testing. So we did have testing availability, and staff could test if they had any symptoms. So there was a lot of issue about when they should return, because obviously it's shortened the number of staff you had if they were off sick for a long period of time. So you needed to know when they were fit and safe to return to work. I think the issue is more around asymptomatic testing, because at the early days we didn't know that the disease could be spread by those who weren't showing any symptoms, and therefore you didn't know that they had it in order to spread it. Testing was not my policy area, so I may not be the best person to fully explain all of this.
But on that point, sorry to interrupt you.
Yeah, sure.
I think I heard that asymptomatic transmission was recognised by the summer of 2020, certainly by the autumn. Mm-hmm. So it still leaves quite a long gap until Wales introduced testing for all healthcare workers, symptomatic and asymptomatic.
Yes, I think that's about right.
Is it a capacity issue?
As I say, I'm not really the best person to ask about this, because I wasn't involved at all in anything to do with the testing. I'm sorry.
No, all right, don't worry. We'll seek to answer it through someone else.
Okay.
IPC guidance, please. Can we be clear at the outset? What is your role in relation to the approval or otherwise of IPC guidance?
The IPC guidance, we had an agreement to work collaboratively across the UK, and there was a UK IPC cell. Public Health Wales contained our experts, and so we sent our representatives of experts to the UK cell. Once the cell had made advice, it then was brought back to Wales and was presented to the Nosocomial transmission group, because that seemed a sensible place for it to go. But it did feature in other conversation, but it was mostly at that.
Right, so you saw it as part of your role on the NTG?
That's right.
I'm sorry to interrupt you, but did you then comment on the guidance?
So the NTG looked at the guidance and looked to see whether or not there were things in it that didn't fit or might be challenging for us, or a sense check, I suppose it would be. The people who were sent from Public Health Wales also sat on the NTG, so we were able to sort of say to them, so does this sound about right? Were you able to say the Welsh position in the development? So it wasn't like there was a great separation out. We were all one and the same, if you like. So the UK guidance was given to us as a best practice guidance. The NTG then received it to work out what was best for the system. But I understand the UK cell were drawing scientific evidence from things like SAGE and nerve tag, which we weren't involved with at all.
Right. So in your statement where you say the CNO played no role in providing advice or guidance as to the types of PPE or RPE that nursing or midwifery staff should use in the workplace, that is correct in terms of your CNO role, but you had a role reviewing it as part of your role chairing the NTG. Is that a fair way of summarising it? And can you recall now any examples of you in your NTG capacity saying to the cell, we don't agree with that recommendation, or that bit of guidance we'd like to reword or amend?
No, I do recall us talking about face coverings in non-clinical areas, which we referred to earlier. But on the whole, because we'd had experts from Wales help design it, it mostly fitted our system. So there was very little, oh no, we don't agree with that kind of conversation.
I think you were made aware, though, in your CNO role of issues in relation to FFP3 masks. And if it helps you, Professor, it's at paragraph 309 in your statement. You say that there was issues regarding the fit and suitability of PPE raised with you during meetings of the nurse directors. And you give an example there that on the 3rd of April, concerns were raised around FFP3 face masks used in critical care that were not fully waterproof, and staff were resorting to double masking. I assume that means wearing 2 FRSMs, does it? Mm-hmm. And how were those concerns? So they were coming to you from nurse directors, what presumably from the front line to the nurse director and director to you?
That's right. So we had a PPE cell which pulled together folk from procurement who knew about the supply chains and what we had in stock, along with folk from service, which is about distribution and so on.
Right.
So my role here was really to make sure any issues I came aware of were reported to the cell for them to take action on. And that's what I did. Whenever there was an issue raised about any PPE, whatever it was, or shortages or difficulties in accessing it, I made sure it was reported. We had a lot of stock. Often the issue was around distribution. So people on the front line were not necessarily receiving what they wanted. We didn't run out of stock. It's just not necessarily, we had everything, but not necessarily in the right place.
Right. Let me ask you about that specific example there, though. There was a concern about the masks in critical care not being fully waterproof. What did you actually do when a concern like that, who did you tell? How was it resolved?
So I think in the text here, I mentioned I talked to David Goulding, who was our health emergency planning officer, because he was part of the cell. But in other examples, I would have gone to Dr. Chris Jones, who was the Deputy Chief CMO, who was chairing that cell. If it was, depending on what it was that was the issue, I would report it to a lead policy officer in that cell. If I felt it was a distribution thing that might be inside a hospital, because I think I gave an example further on in my statement about that, I would make sure I also told the nurse director, I've heard from your staff there's an issue. I think you should look to see if that ward or that team are actually getting access to the things that they actually need. So sometimes it will be back down the chain rather than into policy. So I was more of a conduit of information than a fixer of the problem.
Right. And I think you set out in your statement a number of other problems, for example, straps perishing.
Yes.
You also dealt with an example on the 19th of May where you, in one of the nurse directors, noted that up to 50% of FFP3 masks were failing fit testing. Mm-hmm. I just wanted to be clear about that. Did you mean that the fit, it didn't work 50% of the time?
Yes. It was a lot of it was not suitable for the staff there, so they couldn't fit them tightly to the face, so that you could have a good seal. So I would say, if we come on to recommendations, we need to think about having masks that fit different shapes of face. Different ethnic groups have different shapes of face. If you have a beard, it's very difficult to have a good fit. So there's lots of things around fit that probably need to be looked at in the type of stock we have.
Were you made aware of any specific issues regarding PPE fit for ethnic minority nursing staff in Wales?
That's what I was referring to there. Some of that was to do with that. If you have different shaped face, it is a little more difficult.
You mentioned to my lady that in due course there might need to be a recommendation about broadening the types of masks that might fit different type faces, but if you're made aware of a problem with PPE fit for ethnic minority staff in Wales, what steps did you take to try and address that, given you can't just rustle up a new mask overnight?
No, again, I fed it into the PPE cell because they are the ones that were working with our NHS shared services. What we have in Wales is an arrangement where all the health boards fund one body to do things like procurement for them. It's a way of saving money and being more efficient. So if they became aware that they needed to have different kinds of equipment, that would be the place where the procurement would be dealt with. So that was the route back, and they sat on the PPE cell.
Now I turn to visiting restrictions.
Okay.
We have heard that visiting was restricted unless there were a number of specific exceptions that applied, for example, end of life or a woman in labour. Can I ask you this? Did you have any role in developing the restriction on visiting guidance?
Yes. It was I was the lead advisor on that.
Okay. In developing that guidance or determining that you shouldn't visit unless you're in one of the exceptions, did you consult with any people like disabled groups or any of the groups that might be impacted by that decision before coming to your ultimate view?
So there were 5 versions of guidance. So if I take us at the very, very beginning, when the complete lockdown came, the nurse directors asked me to set out a policy position for Wales because they felt they needed to have one voice for Wales, and the Welsh Government was able to do that for them. and I agreed with them what it is that they thought was suitable for the NHS. And so the very first iteration, which was in the beginning of middle of March, 20th of March, I think it was very restrictive. Over the iterations that followed that, it became far more nuanced and far more permissive as we heard more voices saying about the impact and certainly issues around folk that may have dementia or other cognitive learning, about the importance of people who might need an interpreter. So there were lots of folk that might need to accompany a patient in any part of their hospital journey, would need to be involved. So yes, we listened, but in the very first, I was responding from a request from the nurse directors in Wales to say, please, Jean, will you just give us a statement about what we should do to lock down? There was a tremendous amount of fear at that time caused by it, and visiting, they were fearful for the staff for bringing it in. I have to say, visiting and the role I played in visiting is a thing that has stayed with me the most out of all my experiences during this, because I was acutely aware that stopping loved ones being together, stopping a father seeing the first blip of life in an antenatal scan, you don't get that back again. And to this day, it's the thing that I reflect on the most, I think, and with the heaviest of hearts, that I did it at the time and was able to hopefully listen and respond as more and more voices came to us about changing it. But always it was a balance between what the staff felt they could manage with in the environments in which they are working, given the lack of vaccination in the first 3 versions of the guidance. That's, we didn't have vaccines until December. So all of 2020, this was done in a time where the staff are very fearful. Did we get the balance right? I'm not sure we did all the time.
Is it a necessary evil, or was the balance not struck? What do you think?
Well, as time went by, we got much better at giving guidance around taking a risk-based approach. And as we started having lateral flow tests and point-of-care testing, so we knew a lot more about who was carrying disease, and having a vaccine that protected a lot more people, some of those risk-based approaches became easier to do. But in the first period of between March and December, when the vaccine came in, staff anxieties were through the roof about this. Now, I always wrote into the guidance that we needed to be as enabling as possible, particularly at end of life. The last thing I ever wanted was somebody to pass away without their loved ones having contact. And that was, even from the get-go, when we locked everything down, I always said that was something you should enable. We got more and more permissive, if you like, in the guidance, but it was only ever guidance. It wasn't you must under... it wasn't legislation, it was guidance to service, and they were allowed to depart from it.
Although it comes with that a inconsistency depending on which board, which hospital, maybe even which ward.
Indeed.
All right. Can I ask you about, I think, a change that was made in Wales, where there was a relaxation in July 2020, whereas providing the visitor did not have COVID and the visit was agreed in advance, then the visitor could come onto the ward. But PPE may need to be worn and there may still need to be social distancing. I appreciate that was an attempt to allow more people to visit, but do you think that was an onerous ask to make of people who had to, the staff who had to manage the visitors? Make sure they were COVID negative, provide them with PPE, make sure they were socially distancing, agree this all across a ward. What do you think about those considerations?
Well, it's a fair point. However, I go back to saying there was still a tremendous amount of anxiety about this because we didn't have a routine testing of visitors. And I should say a word about the lateral flow test. It isn't 100% accurate. There are lots of false positives, false negatives. So it wasn't like it was a sure, fast way. If you did a swab that says you're clear, you might still be carrying the infection. And when we didn't have the vaccines, which was the case in the summer, staff were keen that if folk were coming in, they wanted to be as safe as possible for everybody, because the last thing you would want to do is either give it to the staff or to another patient or another relative visiting. So they did have to manage their environments to keep it safe for everybody.
Thinking about maternity services in particular, was it right that in Wales, women in labour should be permitted a birthing partner from their household from the 25th of March 2020? Was that the general rule?
Well, it was for them to have a birthing partner, yes, when they're in active labour. And it stayed like that in the next further 2 iterations, so 3 iterations. That was the case.
So we heard from Dame Ruth this morning that certainly the guidance in England didn't make a distinction between active and non-active labour. In Wales, was it only allowed in once in active labour?
That's right.
Right.
The reason being it's to do with the geography, because if you are starting off early in labour, you might be in a ward with many other people. When you're in active labour, you're taken into a room on your own, so it's much easier to manage. So it was a practical, physical thing that kind of helped with that.
Were you aware of examples of women being examined vaginally to prove they were in active labour and therefore have the support of their partner?
And that wasn't told to me, and it sounds extraordinarily distressing if that was the case. Normally, there would be examinations as normal part of it to
check where you are.
Where you are, exactly. So I'm not sure if anybody would do it just to have their partner in. If they're in active labour, they ought to have support. And we increased the type of people can come with them. So if somebody needed extra support because of whatever issue, they may have a mental health problem or a language problem, we also said that they may have an essential worker as well as a birth partner. That came later on, because we listened to what people were saying to us.
Just standing back and thinking about the visiting restrictions, would you make the same decision next time?
Well, fortunately, I don't have to do this again because I'm retired. Should I be next year?
Were you in that position?
Were I in that
Would you
position?
make it again?
I think I would like us to be more permissive earlier on and find ways to do it. And I would say in particular areas, neonatal services, I've reflected on this quite a lot. I think both parents should have always been allowed to be with their child. I certainly was affected by the Bliss report that described what the impact on was having not the two parents seen as a unit, if you like, rather than one parent in there and the other parent not there. Neonatal care is very fraught, and often the child may not survive. So it's a very difficult area. And I think on reflection, I would have said they always should be as a pair. And other areas, I think we should have been much more careful around giving support. So if somebody's got dementia, it's a very difficult situation, and having somebody they have some recognition of. So there's lots of folk that I think we should have made more exceptions of earlier on. So yeah, I wouldn't have done exactly the same thing all over again. But hopefully next time there will be a vaccination sooner, so that we could be more confident in doing that anyway.
Can I ask you please about DNACPRs? Were you made aware of any concerns that they were being issued inappropriately, or there was blanket use of them in Wales?
So I had heard from various groups about concerns about having a blanket do not resuscitate cardiopulmonary resuscitation. They came from the disability advisory group that advised into government. But I also was aware from Healthcare Inspectorate Wales, which is our inspectorate body, that they'd come across one GP practice that sent out a letter suggesting to their patients that perhaps you should all consider, not all patients, but certain groups of patients should consider signing this, which is completely inappropriate. Every bit of guidance we've ever issued before the pandemic, during the pandemic, makes it very clear that these conversations should be individual, should be based on agreement with the patient and their loved ones, and about what's best for them in their care pathway. Under no circumstances, and I think Ruth may have said this morning, under no circumstances is a blanket approach ever appropriate.
Can I ask you about an example, if that be the right word, behind your tab 15 and at INQ 30091 _9, please. Which is a note of the Executive Director's daily calls on the 3rd of April. It's probably going to come up on screen in a moment.
Okay.
There we are. I just want to ask you about the PPE box.
All right.
I know you're not in this meeting, but there was a discussion held on PPE, and specifically on ventilators. Deputy Minister has had discussions with Tai Hafan. Is that a hospice service?
It's sheltered accommodation.
Sheltered accommodation, all right.
T. Havan is...
I'm so sorry if I pronounced it
okay.
incorrectly. As their service users had received a letter from their GPs which said that if they caught the virus and were seriously ill, they wouldn't be resuscitated. And, you are in it, forgive me. You and your colleagues were working on the ethical framework.
Yes, there was a moral and ethical framework that Dr. Heather Payne and I and others worked on and issued, which sort of was to help people make the right kinds of clinical decisions in extraordinary circumstances. And it was certainly highlighted in that. But there were also subsequent letters that the CMO and I wrote out reminding people about not doing blanket do not resuscitation. Or
Did you ever see the letter? From the
I didn't
GPs
see
in
the
this
one,
example.
not that example, but as I say, I heard from different sources. That wasn't the only example I was told about. It came from a number of routes.
May I ask you about long COVID,
Yes.
please? Was any data collected on the number of nurses and midwives that reported symptoms of long COVID?
No, it wasn't. As far as I can see, the health boards would have kept their own records about staff sickness, but there was no central reporting back to Welsh Government then, or I don't think that even now that we know exactly how many staff have got long COVID symptoms, and certainly not in the time I was a CNO.
Well, I was going to ask you, did it come to your attention during your tenure?
No. I was aware that some people were taking a longer time to recover from it. So long COVID became a thing during my tenure because the Welsh Government started work on setting up a framework of how to support patients and members of the population, and that would include staff members who developed the symptoms of long COVID.
Final two topics from me, please. I'd just like your assistance, please, Professor, on the impact on the nursing and midwifery profession in Wales, and starts in your paragraph 287, if it helps you. Told us about some of the support that was provided and practical help for nurses and midwives. Can you, though, give us, if it's possible, an overview of the impact on the profession in Wales?
I think it was an extraordinarily difficult time for anybody in frontline services and for the people who were managing the services, because obviously I was seeing that the senior leaders, they were having to make extraordinarily difficult decisions as well. I think it's had a long-term effect on the health and well-being of many people. We have seen people leave the service as a consequence of their experience, and because of that, we've had to continue offering a wide range of national support that has been described in my statement of my two successors, and I've touched on them before. Health Education Improvement Wales has this very large reservoir of resources that are there for people. The sort of Health for Health Professionals programme is still there. There's now a programme called Adferiad, which is a Welsh Government funded service for staff with long COVID. It has taken a much more of holistic approach rather than a disease approach. This is about helping people's mental health, mental well-being, getting physically active again. So it's a much more rehabilitative model than a medical model. But to be honest, the legacy of COVID is going to be quite long. And obviously I'm retired now, but I see the stories about people leaving the workforce, and certainly reports like the Royal College of Nursing
Well, I was just going to ask you about that, if I may.
Yes.
And if it helps you, let me just summarise it. But I think you received a query from Vaughan Gething about a report of an RCN nursing survey in November 2020, which highlighted that 34% of staff, nurses in particular, felt undervalued by the Welsh Government. This was the highest figure of any government in the UK. And 74% of staff believed they'd seen an increase in the stress levels. I don't doubt that the Welsh Government didn't want to undervalue their nursing and midwifery profession, but the stress levels, how were they addressed?
So obviously receiving a report like that is very concerning. I was worried about the staff then, and I understand the longevity of the condition, how it's affected people's health and well-being after the surge of pandemic is now still an issue for a lot of people. And I had a conversation with a lot of my colleagues within Welsh Government about what more could we do, what more can we respond to. And as I said to you before, we already had a series of programmes of work underway to do with the mental health and well-being issue. And there was a Welsh Health Circular, which is an instruction to the health service issued by Andrew Goodall, reminding all the health boards and trusts about their employer responsibilities, about providing well-being services. So there was a pushback from us. It wasn't just Welsh Government that needed to do this. All the employers needed to do something about it. I think I was also aware that the report was part of a call to address pay and conditions. Okay. So an element of this, I had to talk to my workforce colleagues who are involved in pay negotiations. So this isn't something that Wales does in isolation. It is part of a UK pay thing, and both the UK RCN report and the Welsh RCN report also make a claim about we need to be recognised, and staff will feel more recognised if they have more pay. So I'm not trying to diminish what they're saying, because the stress was really real and the effect on their health and well-being is pronounced. I couldn't do anything about the pay, though, I'm afraid.
I think you were aware, though, of the disproportionate impact of COVID on the Black, Asian and minority ethnic healthcare workforce. And is this right? There was I think you asked that nurses took into account where they were deployed to try and presumably mitigate that disproportionate impact.
Yes.
Can you help us, please, with the All Wales COVID-19 risk assessment tool and how that helped that disproportionate impact, if at all?
Okay, so early on in the pandemic, the First Minister asked for a series of work to be done to look at the impact on the Black, Asian, minority ethnic population in Wales. And one of the groups that was established was to look at developing a risk assessment tool for all staff, not just people who are Black, Asian and minority ethnic. And it took the learning that we had to that point about who was more at risk. So people who are older, people who have diabetes, or and so on and so forth. So it wasn't just what ethnic group you were from. The tool was developed and issued in May of 2020, I think, 20th of May, sticks in my head. And it was sent out both in paper form and then electronically. And all staff within the system were invited to complete it and then go to their manager to say, I've assessed myself either as low risk or medium risk or high risk. It's like a traffic light system, so you could work out where you are. And if you're in a high risk group, then it's a reasonable suggestion you should be deployed somewhere not in front line. I should point out that the people who are excluded from that were people like myself who were clinically vulnerable or shielding, because we expected them not to be in front line. In fact, not to be in work a lot of the time. The shielded people were at home. So it was designed for everybody else, if you like. That changed when the shielded people came back, so there is a second iteration of it. So I did ask to find out, so how many people from Black, Asian and minority ethnic background, staff-wise, had completed it. And you'll see in the pack there, I think, that all of the directors of workforce in each of the health boards and trusts came back to say, yes, everybody has completed this. Right. Even when the IT systems didn't quite capture it automatically, as another element of the IT systems, they were still able to do it paper-wise to track down. So everybody was able to do it. And most were in a low-risk group, not in a high-risk group.
All right. Finally, this, please. You've obviously endorsed recommendations in relation to testing and the rollout, but if you were to provide my lady with another alternative, perhaps Wales-based recommendation, what would you say would be the most important thing from your perspective that could help the nursing and midwifery profession in Wales?
I think my reflections from the time would be around infection prevention and control expertise, both in terms of every staff knowing more about it, but also having expert leadership. We really struggled during COVID to actually have people who had the right knowledge and had the senior leadership in this area. So I would say we need to invest in that pre-registration existing workforce, and I would say there should be a senior leader in each health organisation with expertise, rather than somebody who's a leader who covers infection, if you see the difference there. So that would be my first. Am I allowed a second one?
My lady, they're all the questions that I have. Is there anything that your ladyship would like to ask or follow up on?
Professor White, there are some questions for you that I think might take something like 20 minutes. Are you okay to come back after the break?
Of course.
Thank you very much. In which case we'll break now and I shall return at 10 past.
Thank you, my lady.
Mr. Weatherby, are you asking the questions or is Miss Monroe? I thought you were the one sitting there. And when I saw Mr. Weatherby arrive, and it says Mr. Weatherby on my list, I got confused. Miss Monroe.
Good afternoon, my lady. Good afternoon, Professor. My name is Alison Munro. I ask questions on behalf of COVID Bereaved Families for Justice UK. I'm instructed by Nicola Brooks of Brady Jackson County Solicitor, who assists me today along with Counsel Oliver Lewis. Just a few matters, please. 3 discrete topics and a couple of questions on each. My lady, some of which have been sufficiently addressed by Ms Carey, King's Counsel, so I won't trouble you with those. First topic. Relationships with Wales and the CNOs in Wales and the other CNOs in the 3 other nations of the UK. Now, I'm mindful, Professor White, of the evidence you gave this afternoon that the role of the CNO in Wales is a substantive civil service one, as opposed to somebody like Dame Ruth May, who has an NHS role. With that in mind, could you assist us as succinctly as possible here, please, with what communications did the Welsh CNO have with other CNOs across the other nations of the UK? I know it's a rather broad question, and what I have in mind are sort of the nature and effectiveness or otherwise of those communications, please.
So each part of the UK has a chief nursing officer who gives advice to government. They have slightly different roles, but essentially that's what we do. Before the pandemic, we would meet on a quarterly basis, either in person or virtually, to help drive the professional agenda forward. Because nurses and midwives are regulated to work anywhere in the UK, we needed to have a shared understanding of what that would mean. We can't have health policies completely different because it would make it difficult for nurses to work across the whole system. during the pandemic, we just increased the amount of contact we had, partly to give peer support, but mostly so that we could learn from one another the approaches being taken in our health systems, so that good practice could be shared, or assistance to find solutions. So I'll give an example, that the hospital visiting guidance, we talked about that so that we all were taking similar approach, so there was less difference geographically.
Thank you. On the 30th of March 2020, nursing directors raised concerns regarding delays in the publication of Public Health England's guidance on dealing with deaths. Why was that delay in England relevant to what was going on in Wales and decision-making in Wales?
So quite a bit of guidance around infection prevention and control was being developed at a UK level. So rather than each country going their own way, we tended to share good practice, and particularly in infection prevention and control. And we had decided that to take the Public Health England guidance and apply it to Wales in this particular instance.
So was the reality, as you saw it, that Public Health England was making the major decisions and Wales were following suit? Or was it more collaborative than that?
I think it was more collaborative than that. There can be a lot of wasted energy if everybody had to go from first principles and develop guidance. It's much better to share information and then apply it to systems if we all agreed that original piece of work was sound. So yes, it was more of a collaborative and building into application to our own systems rather than develop from scratch.
And lastly, on this first topic, about temporary registration of third-year student nurses. We heard a little bit about that this morning from Dame Ruth May. On the 17th of April 2020, in a nursing directors meeting, concerns were expressed that temporary registration of third-year students may hinder their progress and delay full registration.
Yes.
Now, a decision was taken in Wales not to adopt the NMC's emergency standards, which was placing third-year students in rostered aid employment.
That's not correct. We did place third-year students in the last 6 months of their role into paid employment. They weren't on a temporary register, that was the bit.
Right.
They were still students, and the hours they did in practice counted towards their degree. I'm sorry if the note was not clear enough. So they were paid as a Band 4 healthcare support worker for that 6 months, and they had a 6-month contract dated from the 27th of April 2020.
So in that respect, Wales was not adopting a different position from the NMC's emergency standards. I'm grateful for that clarification. Thank you. Second topic then, communications within Wales. My first question has actually been addressed. It was about the absence of a CNO role in pre-pandemic planning. That's been sufficiently addressed by you already. But my second question is this, Professor White. Do you think there was a gap in the communication between health boards in Wales and the CNO, bearing in mind the absence of a CNO role in the pre-pandemic and emergency health planning?
I had a very close relationship with the executive nurse directors. Wales is not a very large place, so we met regularly before the pandemic, and I met with them twice weekly during particularly the first wave, and then it reverted to a less frequent contact and then increased again as the second wave came along. So I wouldn't say that I had a poor relationship. It was a very good relationship, actually. Did you have a specific area that you felt that was difficult?
No, it wasn't so much about the quality of the relationship, whether it's poor, whether there were any gaps in terms of the communications.
I didn't feel so at the time, no.
I'm grateful, thank you. Last topic then, the CNO's ability to act on concerns. Now, the word concerns is something that is repeated throughout your very lengthy and very helpful witness statement. You've already told us in detail about the visiting guidance, and you were the lead in relation to that. So that takes care of my first question there. So my second question in terms of concerns is this, Professor White. At a meeting on the 10th of April 2020, concerns were raised about the deployment of returning staff over the age of 60 years of age into COVID-19 areas. And this was particularly so, this concern was raised because of the very well publicised at the time numbers of older staff in Italy that were being affected.
Yes.
What actions did you personally or collectively with others take in terms of addressing those concerns?
So that was back in April. So it was raised at a meeting with the other nurse directors. This was from Cardiff and Wales University Health Board nurse director raised it. So that practice was shared with others at that moment, but it was fed into the development of the Wales risk assessment tool that we developed for all health workers. So age on its own is not necessarily exclusive. It's the things that go with age. You often have a chronic condition like I have when you're older. So age was one of the factors that was described in the risk assessment tool that all workers were encouraged to do to work out how susceptible they might be. And that included other chronic conditions or from a Black, Asian and minority ethnic background. And in fact, men were more susceptible than women, for example. But that on its own wouldn't be necessarily a thing to move you to somewhere else. Does that answer your question?
It does. Thank you very much, Professor White. My lady, thank you. Those are my questions.
Thank you, Ms Munro. Very grateful. Now you have questions from Miss Wira Atney, Casey, who... have you got a direct line of sight?
Yes, I have. Thank you very much.
Thank you, my lady. We have an excellent line of sight. There's just a pillar between you and her, which I'm sure I can navigate.
I'm afraid we always knew that would be a problem. Sorry.
Thank you very much. I'm asking questions on behalf of the COVID bereaved Families for Justice Cymru, and many of whose members were bereaved through the loss of loved ones to nosocomial infection. You may already know that this group is critical of the Welsh Government's response to the pandemic and, amongst other things, has said that it was slow and disjointed. So I do have some questions for you remaining, and they will involve a little bit of context setting, so if you would just bear with me on that. First, I wanted to ask you about timings of responses by 3 of the Welsh Government bodies that responded. And the context of the questions is that of urgency. So on the 30th of January 2020, the WHO declared a global public health emergency. On the 4th of February 2020, SAGE confirmed the first case of human-to-human transmission had occurred outside of China. And on the 28th of February 2020, COVID-19 struck for the first time in Wales. So first question on that is from paragraph 68 of your witness statement, and you don't need to look at this. You say it was only on the 16th of March 2020 that the executive team meetings of the Health and Social Services Group to discuss issues affecting planning and delivery of health and social care in Wales stepped up frequency of its meetings from monthly to weekly. So bear with me. And then secondly, at paragraph 69, you also say that on the same date, the 16th of March, monthly Welsh nursing directors' meetings increased to twice-weekly meetings to share information on service issues that may require Welsh Government response. So the first question is, do you accept that increasing frequency of these meetings in key groups on the 16th of March was too slow a response to an already urgent situation?
Some groups were meeting sooner than that, so I think it'd be fair to say that the planning and response cell actually started meeting in February to start working out how the system could change. So it was certainly certain meetings were starting to step up its frequency during March. Possibly it was later than that could have been done, but I'm not sure what more we could have done earlier until we had some of the plans in place, which other groups are already working on.
So I think that I was going to ask you that. I mean, of course, I was talking about key groups in relation to the executive team HSSG group and the nursing group, which you would accept are key groups, wouldn't you?
Yes, and the executive director team meeting was weekly. So I would meet with other colleagues and the Director General on a weekly basis, usually a Thursday morning, and that was supplemented by daily contact as soon as the pandemic really started to get its claws into us.
Right. So if I was to ask you to offer an explanation for the delay in start of the 16th of March, would you have anything additional to add?
I don't think so. As the work escalated, so our need to meet more frequently escalated alongside it. I'm not quite sure whether meeting more frequently before that for some of these groups would have been necessarily helpful. Hindsight's a wonderful thing. Possibly. I don't know.
Well, let me ask you another question on that point. The Welsh Government's Nosocomial Transmission Group was established on the 19th of May,
That's right.
2020. Its role, you've already been asked about, was to provide advice, guidance and leadership on actions needed to minimise nosocomial infections. So you were the joint chair of that group along with Chris Jones. Again, referring to the state of knowledge in January and February regarding the virus as it emerged, and that nosocomial infection had been identified by SAGE in March 2020 as being a pressing issue, do you accept that the 19th of May 2020 was too slow a response to establish a Welsh nosocomial group?
Yes. Well, Public Health Wales were working on the infection prevention and control issue. The IPC cell, I think, had met in January of that year. So we were relying a lot on the expertise and support of Public Health Wales. It was decided that additional support would be needed at a government level. Possibly we could have started it a few weeks earlier, I accept that, but certainly it became a focus of our attention, and we met very, very regularly throughout my time as CNO.
Yes.
And produced a lot of guidance as a result.
But you accept there was about a 6-week delay between the SAGE announcements and your group being set up?
As I say, that was because we had other mechanisms that were already in play. So this was an additional thing we added later on. I wouldn't call it a delay particularly. It was as the issue started to emerge, we realised we needed more support and a place where we could work on broader guidance rather than the immediate infection prevention and control measures that Public Health Wales already was dealing with.
But as we know, it became a pressing issue, nosocomial infection, and you were asked about outbreak surveillance monitoring, which you said in evidence came later on. Now, it's correct, isn't it, that later on means November 2020, so that's yet another 6 months after the setting up of the nosocomial transition group. That's correct, isn't it?
So what I said in my statement was that we had a pre-pandemic arrangement that Public Health Wales dealt with all outbreaks. But the way that their data was presented to us as a Welsh Government was there's some time lag. So we didn't know every day what was happening across the system. So we had to develop a way of gathering real-time data. So I would say, yes, there was a delay in having real-time data, not that we weren't actually managing outbreaks in a particular way. It just wasn't timely enough. So that would be fair to say that, yes.
Yes, because the daily reporting didn't start till November 2020, and that's the evidence you referred to earlier. So in relation to what I'm going to call slow responses at this critical time in Wales, it would be correct to say, wouldn't it, that valuable planning and response time and data was inevitably lost?
Certainly certain systems had to be established, and I would say that was slowed to happen. Some of our systems, IT systems, I think my lady already mentioned that some of them didn't talk very well to each other. So it's quite hard as a government level when you don't have access to real-time data. So that certainly took a while. We did have a planning cell that was working with the service about how to change what we were providing. So that was done in a reasonable time. I wouldn't say it was early, but it was reasonable. So it's a mixed answer, I would say to you. Some of it was possibly slower than we would ideally like because we had to establish systems.
Thank you. I'm just going to move on to another topic now because I only have 10 minutes to ask you questions. So within your statement, you do explain that on the 3rd of April 2020, a conflict was brought to your attention by directors of nursing between the Public Health England PPE guidance and the UK Resuscitation Council guidance in respect of whether CPR and chest compressions constituted AGP and whether in hospital settings, at least, full protective equipment should be worn, including FFP3 respirators. Do you know what I'm referring to?
Yes, I do.
So on 10th of April, you were told that practitioners in Wales did not want to use the Public Health England guidance. Can you confirm that on the 21st of April, you received an email from one nursing director of a local health board alerting you to the fact that some health boards were insisting on accepting the Resuscitation Council position over that of Public Health England?
Yes, it's remained quite a contentious issue within the service for a number of months. It wasn't just that one instance. We talked about it multiple times as executive nurse directors. And in the end, the CMO and I actually put out what we hoped was helpful guidance to find a way through while the scientific experts looked at the issue. I'm not an expert in this area, so this became a problem for some months, and eventually an aerosol generating procedures specialist group was established at the request of the senior
I'm
clinicians.
going to interrupt you if you don't mind me. There was a specific line of questioning that I wanted to follow.
Okay, go ahead.
But I want to be fair. On the 14th of April, you did issue a letter, which is in your statement at paragraph 208, I believe. You've set that out there. But I just wanted to ask you this. So you did receive that. There was an insistence on the part of some local health boards to use the RCUK guidance. Mm-hmm. And you forwarded that, didn't you, to Frank Atherton, then the CMO of Wales, and also to Chris Jones, the deputy CMO. And you stated, in quotes, "As I said before, I wonder if we should have made a decision to just accept the Resus Council position as best practice for Wales, given the level of distrust now apparent within the PHE-PPE guidance." Bear with me. The response you received from Chris Jones was that it was not for the Welsh Government to mediate the standoff between the RCUK and PHE, that the Welsh Government supports the PHE guidance, and that it was for organisations to consider what advice they wished to adopt. And Frank Atherton said that there should be no further action. So my question is this: do you agree that further action should have been taken to provide clear leadership in respect of the PPE guidance to be used in Welsh hospitals on CPR, during CPR?
So Frank and I did actually send a letter, I think it was about a week after that, which tried to mediate a way forward while the issue was being sorted out. So this needed to have further scientific view on it. The whole issue about whether chest compressions causes aerosol particles to a degree that would actually cause a risk to staff. So we tried to be helpful, but it wasn't really Frank or I's place to try to sort out the scientific argument that was going on.
So do you accept, though, that the argument, if you like, was causing confusion on the ground?
It did.
And that patients and staff were at risk as a result?
Probably.
Yes.
I mean, all I can say is we tried to find a way with advice to mitigate the risk, but certainly having the confusion added to a distrust of guidance that was coming out, and that was not helpful to anybody.
So that was my final point on this, in relation to the distrust of guidance. And my question is this: did this attitude of distrust by the local health boards spill over into other aspects of PPE guidance and damage the confidence in Public Health England's guidance and compliance by hospital staff in Wales?
Possibly, but it was not reported to me as an issue as clearly as this. This was, I would say, the standout conflict between advice that was given to staff. It may very well have made people question what other guidance was out there, but it needed to be clarified to help. So I can't give you another example, I'm sorry.
All right.
Thank you.
Thank you very much. Those are my questions.
Thank you very much. Thank you very much indeed, Professor Wright. I'm really grateful for your help. I don't know if it's pleasant meeting your former colleagues in this situation when you've all got to relive such a dreadful time. But anyway, thank you for coming along today.
Thank you very much, my lady.
Thank you very much.
Ms. Carey.
May we now hear, please, from Mrs. Fiona McQueen, who's just coming in.
Right. Would you like us sworn?
Yes, please.
I swear by Almighty God
That the evidence I shall give
that the evidence I shall give
shall be the truth,
shall be the truth,
the whole truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
You've been waiting a long time. I'm very sorry.
It's not a problem, my lady.
Mrs. McQueen, your full name, please.
Fiona Catherine McQueen.
I think you were initially the interim Chief Nursing Officer in November 2014, became the Chief Nursing Officer then until February 2021.
That's correct.
Can you just help us, please, with your own professional background? Just summarise that if you...
So I essentially am a generalist nurse leader. I became an executive nurse director in 1993. So the bulk of my clinical practice has been in nurse management or executive nurse director roles. So generalist leadership across a number of areas.
I think you are... the Chief Nursing Officer has its own directorate, which sits within the DGHSSC, or the Director General of Health and Social Care in Scotland.
That's correct.
And your roles and responsibilities are set out in your statement, but they include providing policy and professional advice to ministers and leading on professional and policy aspects of healthcare-associated IPC and antimicrobial resistance measures.
Yes,
A mouthful, but is that it in a nutshell?
that's it.
All right. You provided advice to a number of groups, I think, during your tenure as CNO Scotland, including the Health and Social Care Management Board. I know that was briefly reconstituted to be called, I think, the Health and Social Care Planning and Assurance Group before going back to the board. Is that right?
That's right.
Just tell us, what was the board's remit?
Essentially, within Scotland, the NHS is run by NHS boards from a legislative perspective, and the Director General is also known as the Chief Executive of the NHS in Scotland and the Accountable Officer financially. And the Director General has a team of directors, including the Chief Nursing Officer, and we would oversee policy on health and provide advice to ministers, but also look at enabling that policy to develop into strategy for delivery of the NHS.
I think one of the other advisory groups that you either attended or was associated with the CNO and the Directorate was the COVID-19 Nosocomial Review Group, or CNRG as it was known. Was that something that you set up alongside the CMO in Scotland?
Yes, in Scotland I think we have a very effective national group. Now, over March to April 2020, Health Protection Scotland, we had the creation of Public Health Scotland and Health Protection Scotland, which was NHS RHI, the derivative of that. So sometimes HPS and NHS RHI are used interchangeably. So we had a good system in Scotland for oversight of nosocomial infection, antimicrobial resistance, and that was there. Obviously, during the pandemic, there were other bodies nationally across the UK that were set up. But I wanted, after a few weeks, I realised there was a gap, and I had wanted to have a more expert group who could look at what was happening in SAGE, look at what was happening internationally, and provide advice to myself and Gregor Smith, the CMO, and we could then onward to ministers or into the service. Just wanted something that was more locally applied to Scotland, more responsive to our questions and our direction, and able to formalise what was happening within Scotland.
And I think you said in your statement that group first met on the 7th of May in 2022. And if I understand it right, are you actually a member of the group, or do they report to you?
They reported to me.
Right. And the CMO
Yes.
as well. All right. Were you involved in any advice giving to ministers between January and March 2020? Sort of the pre-pandemic phase.
With regards to IPC or in general?
In general.
No, a lot of that was done by the CMO, the Cabinet Secretary for Health, and the Resilience Unit did a lot of that work. But we were beginning to ramp up in terms of looking at the student nurse, our senior student nurses moving into employment, similarly with the ITU guidance. So I wasn't involved in the national advice that would be happening nationally across Scotland. It was more bespoke with regards to the nursing and midwifery workforce.
Fine, thank you very much. Can we look at the CNRG in a bit more detail, please? And I think, if I understand it correctly, it was there set up to try and understand nosocomial infections and identify any other IPC measures that might be needed to try and combat those infections. Is that right?
Yes, I think it's important to clarify nosocomial infection exists, unfortunately. It exists right across the world, and it's a well-known phenomenon internationally. Also, when there is circulating infection in the community, then the people who are in the community bring that into institutions. It's easy to see in the winter vomiting bug when we see the norovirus coming into hospitals or care homes over the winter, which is why visiting can be suspended for particular wards or departments. So I think the understanding of nosocomial infection is quite clear. But what we wanted to have was additional advice from a group on, in particular, because we're not normally, in normal times, you don't have the infection being brought into the organisation. So needing to have advice about how it was travelling through the organisations, what was happening with staff, and giving advice particular to COVID-19. And we very quickly published cluster information and minutes of the CNRG as soon as we could.
I think you said you published the minutes, but did you publish the recommendations that the CNRG made?
So they would be summarised in the minutes.
Right, okay, thank you. And you say in your statement that the CNRG's advice was provided to you and the Chief Medical Officer, and thereafter you and RHI considered the advice and used it to inform policy development. Can you give us an example of what practically you did as a result of CNRG's advice?
So a bit of context as well. Within my directorate, I had policy civil servants as well as clinicians who worked in what we would call the HAI team. The chair of CNRG was also the nurse director of NSS, so was associated with RHI, and there were members of NHS RHI on CNRG. So to say it then went to RHI is correct, but there was a lot of commonality amongst that. Things like whether or not to test staff in high-risk areas, whether or not to look at testing. So one of the early pieces of advice it gave us was where you have an unusual or even one member of staff testing positive for COVID, or a patient testing positive for COVID in a ward, an elective ward, which was not a COVID ward, they recommended testing patients and staff.
You mentioned testing, and I was going to ask you, please, about paragraph 28 in your statement, where I think you say that there was advice from the group to the Directorate in late May 2020, for additional targeted healthcare worker testing to protect highly vulnerable patients in hospital at risk of poor outcomes from acquiring COVID-19. Who were the highly vulnerable group that were being spoken of there?
So this is against the backcloth of testing capacity not being what we would want it to have been. So oncology patients, so inpatient oncology patients, including those who are having chemotherapy, if chemotherapy had started back by then. I know we suspended it for a short time. Care of the elderly, so our frail elderly wards, and also our our wards where we had long-term mental health patients for longer than 3 months. So we thought, the advice from CNRG was, this was a group who were particularly vulnerable, and therefore we would look at testing staff on a weekly basis.
What about those with dementia? Were they as part of this group or not?
So that would be, I do beg your pardon, Ms Carey, that would be part of the older people's wards.
Right, understood. Thank you very much. Can I ask us, please, to have a look at INQ 250382? And Mrs McQueen, it's behind your tab 3, but it might just be easy to look at it on the screen. This is a note from you to the Cabinet Secretary in June of 2020 on the 3rd in relation to healthcare worker testing in hospitals. And you can see it's to propose an approach for healthcare worker testing for COVID-19, further to the advice of the CNRG. And I think that we can see the background to this is asymptomatic transmission and testing. And at that stage in Scotland, only healthcare workers who were symptomatic were tested. And the proposal was to test more to try and identify those who may be asymptomatic. Is that it
That's
in
correct.
summary?
Yep.
And I think you say there, I might just need your help with this, at paragraph 4, latest analysis finds that approximately half of the cases in all of the reported NHS Scotland cluster outbreaks in non-COVID wards are healthcare workers. Can you help us with a cluster outbreak? How is that term used in Scotland?
So the term cluster and the term outbreak are both used epidemiologically within public health and within infection prevention and control. An outbreak would be 2 or more cases where there's a common source, and a cluster would be 2 or more cases, not necessarily needing that common source.
Okay.
So it's an outbreak is a subset of a cluster.
Yeah, thank you very much. And so here, at present, almost 70% of cases in the active clusters are healthcare workers. And then the 6 active incidents involve 26 patients, 59 members of staff. The 118 closed incidents. What's the closed incident a reference to?
It's where the cluster or outbreak has been deemed to have stopped. So no more new infections and not being actively managed.
So it had historically been the position in Scotland there were 118 closed incidents involving the 888 patients, 213 deaths.
Yeah, at that time.
And 862 staff cases. And I think if we just go to page 2 in that document, at paragraph 7, top of the page, thank you, there was some work done on mathematical modelling, which estimates that the weekly screening of healthcare workers could reduce onward transmission from healthcare workers by a further 16 to 23% on top of self-isolation. Although that was an assumption, essentially here, were you asking the Minister to bring in testing for the asymptomatic healthcare worker?
No, I think we weren't asking that as a blanket way.
Okay.
I think the recommendations are in under paragraph 11.
Yep.
I think what we were saying is where there's an unexpected cluster or outbreak, we would want to look at that, and where the infection prevention control teams believe they needed to do that they would do that as well.
So you were wanting to target testing where there were these unexpected clusters or outbreaks. Is there any reason why it wasn't wider and just an implementation of asymptomatic testing across the board? So
I'm not sure if it was close. So we would brief the Minister post CNRG or post something new happening. And I think the Imperial College presented a paper that talked about the value of asymptomatic testing. Now, CNRG looked at that, and their view was it was a theoretical or abstract piece, but in the real world, good infection prevention control measures would actually be more effective because it would reduce nosocomial infection by 80%. And their advice at that time was not to blanket test asymptomatic workers. My sense is if we had had the testing capacity, we would have been there.
Well, that's what I was going to ask you. So there is, if I understand your evidence correctly, there was an evidence-based decision taken not to roll it out more widely. Was that the driver of the decision, or was it the lack of testing capacity?
I think if it had been only a lack of testing capacity, then the briefing that I would have had from CNRG and my team that I would have given to the Minister and I would have talked to Gregor Smith about was, we don't have enough testing to do this. Is it a priority, and how can we possibly do that? So I think it was an on balance. Actually, it may not be productive, and good IPC measures are important with the testing where there are even just one unexpected case. Now, that didn't last because we then moved, I don't think that lasted, because this was before the end of June when we were starting to do the vulnerable patients, I think. So I don't think it was predominantly because there was a lack of testing capacity, but there's no doubt at the early days of the pandemic, lack of testing capacity was a problem.
I don't know if you heard any of Dame Ruth May or your Welsh counterparts' evidence, but they have both spoken to Her Ladyship already about the role of testing. Did you hear any of that evidence whilst you were waiting?
I did hear on and off both Ruth and Jean, but I don't remember testing because I was travelling across London at times.
They both advocated, in short, for an increased amount of testing to help with visiting restrictions and the need for it or otherwise, prevention of nosocomial infections. Do you have any dissent or assent to their views?
Complete assent. Increased testing would have been enormously beneficial, I think, right across society, but since we're here to talk about health, within our health system.
Yeah. Different aspect of CNRG's work, please, in relation to face mask guidance. And Mrs McQueen, it's at your paragraph 35, and I may need to put up on screen the table that you've set out in your statement. Could we have, please, 474-225_13? And I think really you've set out a timeline there of the changes to the face mask guidance that was brought in various stages in 2020. June 2020, there is introduction of interim guidance on the wider use of face masks, decision to introduce the face mask in adult hospitals and care homes for the elderly. And the reason for the change is set out there to help reduce nosocomial transmission in hospitals and care homes. I presume we're talking about FRSM masks.
Yes.
That guidance in June 2020, did that include people working in non-clinical roles?
No, I think that was the non-clinical roles was in September 2020.
Yeah.
It does seem curious now that it didn't, but no, it didn't.
Do you think now you would make a distinction between those in clinical roles and those in non-clinical roles for something as simple as an FRSM?
Absolutely. For something as simple as an FRSM, and knowing now, and it is always difficult to move us from where we are today to where we were then, and knowing now what we know about ventilation, about air throughput, and about transmission, I think it would have been better if we had that as early as possible.
September 2020, as you rightly pointed out, updated face mask guidance to cover now primary and wider social care, primary care including GPs, practices, dentists, opticians, pharmacies, and the wider community care are set out there. Can you help as to why GPs and pharmacists weren't included in the rollout in June 2020?
So they would have been wearing it in patient-facing, when they were seeing patients, but not when they were perhaps in the staff room or, if the pharmacists were in dispensing areas. So it would be the non-patient facing roles then as well.
Okay. And if at the bottom of the screen, we can just see there June 2021, a year on from the initial introduction of the interim guidance. Now we've got wider FRSMs by clinical and non-clinical staff. So is it right that a year elapsed before the recommendation was for non-clinical staff to wear FRSMs?
So by that time I had demitted office at the end of February 2021. So I apologise, Ms Carey. I would have thought from memory that we introduced FRSMs for non-clinical staff earlier than that, but I could...
You think it happened in your tenure?
I thought it did, but I may be wrong. Because there's no... And so when we talk about clinical staff, if you were part of the trades workforce, and that would have included them going into wards and departments in the June 2020.
It's my fault. I'm not familiar with the trades workforce. What do you mean by that?
Well, plumbers, electricians, engineers.
Yeah, okay. If I understand you correctly, though, for the porters, the cleaners, people in that non-clinical role within the hospitals, though, when do you think they were advised to wear FRSMs?
So I think in September. So I think in June 2020 we would have been looking at the introduction for all staff. So we weren't just saying clinicians. So anyone who was in a ward or department, which would be the trades workforce, or cleaning staff, or catering staff, as well as doctors and nurses, would have worn that. But in the workshop, the trades workforce may not have in June 2020, but they ought to have in September 2020.
Okay. Dealing with guidance, but in a different sphere, can I ask you about the IPC guidance, please? If we can take that down, thank you. I think, is this right, that Scotland followed the UK-wide IPC guidance, but in October 2020, Scotland published its own COVID-19 specific guidance. Is that correct?
In terms of IPC?
Yeah.
Or, so it would have been a Scottish version of it.
Right. That's what I was going to ask you. Did it replace the UK-wide, or did it supplement the UK-wide IPC guidance?
So I struggled with the UK IPC guidance because, and the feedback we got from staff was it was confusing going on to have a look online, because the National Infection Prevention Control Manual that we'd had in Scotland for some time was an online manual. And staff were used to going online to check what the most up-to-date guidance was, and then they were sent through to Public Health England, and at times that may or may not have had everything that was relevant to Scotland. So I was always keen that we had very clear and explicit communication for people working within the Scottish Health Service and social care.
So although the UK IPC guidance was designed to try and standardise position across the UK, in fact, did it serve to confuse in Scotland? Is that really where you get to?
Yes.
Okay. You do say in your witness statement that there was 15 times that guidance was issued on a Friday. Was that IPC guidance or guidance across other areas?
I think that the IPC guidance was particularly problematic, and particularly because realistically, NHS and the civil service were working 7 days a week. So in a way, whether or not it was issued on a Friday was kind of immaterial. But smaller, in social care, we had much smaller organisations who had less resource, who struggled with information coming out on a Friday. So I think there were other issues other than IPC guidance that would be issued on a Friday as well, other health workforce issues.
Did you become aware of concerns, though, about it being received, in theory, late in the week, albeit?
Definitely, and it wasn't ideal, but the question was, do we hold it until, because we weren't going to issue it on Saturday or Sunday, do we hold it till Monday, or do we issue it and give people time to get it in place? We didn't criticise people for not having immediate implementation, because some of these things would take a number of days to take over and implement.
Can you think of any way to try and if there is a concern about it coming out on a Friday and saying it's got to be in place by Monday, is there anything practically that you think could or should be done to try and soften the blow, if I can put it like that?
I mean, I think resourcing is an issue. So in reality, coming out on a Friday, I may be wrong, but I'd be surprised if we said this is for implementation by Monday, or there'll be firm words taken. I think we would have said, as soon as you can, could you implement this, please? And we would often give a bit of time for things to be implemented, depending on what it was. If it went to an NHS board, our biggest NHS board has over 20,000 staff, so that's never going to reach the front line in anything other than a matter of days.
And generally, in relation to the IPC guidance, we've heard that there was the UK IPC cell with representatives from Public Health Scotland on it and all the other public health agencies and a number of other bodies. What role, if any, did you have in approving, amending, disagreeing with any guidance that the IPC cell wished to have published?
So I'm a generalist in terms of my leadership skills. I'm not an infection prevention and control expert. I had policy, but in particular clinicians working in my team, and I relied completely on NHS RHI. So if they came and said, this is a guidance that we believe we should be implementing, I may have asked questions and I may have queried parts of it so that I could have a better understanding of how that guidance was formulated before I then advised ministers, because I was not going to have NHS RHI saying, Fiona, I think we should do this, and then me say to the minister, I don't think we should. Right. So I was relying on the clinical experts in NHS RHI and also my policy team to advise me.
Can you ever recall an occasion where you disagreed with the guidance that was coming from the UK IPC cell and pushed back, I think, to use the popular phrase?
So in the early days, when I was unaware of the IPC cell, I think it was late March, because it was the 2nd of April guidance that was being worked towards. My team alerted me to the IPC cell developing guidance. And in Scotland, we have a heavy, not just tradition, our working practice is to work in partnership with the trade unions and the professional organisations. So almost anything that we develop in partnership. And it's in partnership rather than develop it and then consult. And the Royal College of Nursing were concerned because they had not been involved in the development of this guidance, and they had concerns about access to fluid-resistant surgical face masks for some staff. Now, at that time, and again, it seems very strange to think back to when we would ask clinicians to go into, and it was particularly in homes, into patients' homes, and not wear an FRSM. But that was the guidance at the time. If your client or patient wasn't displaying symptoms of COVID and didn't have COVID, you didn't need a face mask. And so my team had signalled to me there was real concern here, because there was a UK body or a UK group trying to develop guidance, and it wasn't listening. So I became involved then, and after that there were 4 tables in that guidance, and table 4. So there was table 1, 2 and 3, which outlined what happened when you either suspected someone had COVID or someone had COVID. Table 4 was where there was high levels of circulating virus in the community, and the member of staff believed they would be better and safer to wear a mask. And that's when we insisted on moving to have a wider level of guidance. Right. I think there was also another time when there was a safety alert, a CAS alert that England had issued, NHS England had issued, that had appeared on the UK website, and I advised my staff that could not happen. We needed to have either completely UK or we just go back to the 4 country. So that there were times, and similarly with a letter I wrote in May about AGP or not of CPR and whether or not staff could wear FFP3 masks on that. I had a discussion with Gregor Smith, the CMO, and we issued a letter to say if staff want to wear that, then they may.
Yes, I think you set some of that out at paragraph 55 in your statement. I won't take you to it, but it in short was the position in Scotland that if staff wanted to wear FFP3 during CPR, then they could, even though that wasn't necessarily the recommendation that was coming from NERV-TAG and perhaps the UK-wide guidance.
And before doing that, I talked to, so I was hearing concerns. I talked to the IPC team because I didn't want to be seen to be trumping them, and I wasn't saying this was IPC advice, but cardiopulmonary resuscitation is such an emotional response as well as a physical response to try and save your patient's life, and I just didn't think it was worth arguing about whether it was FRSM or FFP3. I thought it was better to give people as much support as we possibly could.
Can I change topic slightly, please, and just ask you about the temporary register? We know that certainly by April of 2020, the figures of those returning to the temporary register were broken down nation by nation. And could we just put up on screen INQ 421 170 0004, please? Well, we've looked at this now with your counterparts, and I just wanted to look at the Scottish position. So by the 21st of April, there were 1,272 nurses and or midwives going back onto the register in relation to Scotland. And the question really for you is, how many of those were actually deployed to the front line? Do you know?
So I don't know, but I think anecdotally not that many, because remembering a live registration, we revalidate every 3 years. So somebody they could almost be 5 or 6 years out of practice when they come onto the temporary register. And I've already heard evidence from my two CNO colleagues about choice. So people may not have wanted to go to the front line. And we certainly used people on the temporary register or the other, well, we also had returners within the vaccination centres. But I think there was something about need and demand, so whether or not NHS boards actually needed the additional staff, and in many cases they didn't, and then whether the additional staff wanted to do frontline work or whether there was work that they could do. So, and also, I think there's learning. The onboarding process, although Scottish Government paid for their PVG checks and tried to facilitate it, the onboarding took longer than was helpful.
So happily, you say the boards didn't need the staff returning to the register, but the bottom line is you don't know how many were in fact deployed to the front line. Do you think that kind of data would be helpful or not in the case of Scotland?
I think it would be helpful. I think you have to have a balance between, depending on how good your electronic systems are. If you had good electronic systems, at the press of a button, if you could find out, well, 300 went to the front line, but it would have been adding more bureaucracy and more paperwork to already hard-pressed clinicians and managers. So I think in the future it would be helpful to know, but I didn't feel bereft because I didn't know.
And I think you said in your statement at paragraph 108, I'll just read it to you, you said, I was not aware of issues and concerns regarding the lack of relevant training, the suitability of roles to which staff were redeployed, and or support for redeployed nursing staff and midwives. So no concerns were raised to you about those either coming back onto the register or being moved from one department to another? No,
I'm not saying they weren't there, and concerns would be raised to me in a variety of ways, particularly through the nurse directors who would who I met with on a regular basis, who would signal things, but also anecdotally things could come up, but I wasn't aware, no.
Did you ever have discussions with someone like the TUC, or the Scottish TUC, I should say, about concerns about those who are being redeployed?
So I wouldn't have, but probably twice a week. So the health workforce, so as a director of health workforce who would take the lead on workforce issues, and she would convene meetings probably twice a week, and one of my Deputy Chief Nursing Officers, Diane Murray, would be at that, and that would be whether it was the Royal College of Nursing, Unison, Unite, that would be brought up there.
Can I ask you about a different concern that may have been raised with you in relation to the fit of PPE and around face fitting, and particularly in relation to ethnic minorities and the like. Were concerns raised in that regard with you?
So concerns were raised, so even predating the pandemic, there was always a niggle about face fitting, and everyone should be should have had face fitting. It was something that was sometimes tricky because people didn't see the immediate need to have an FFP3, so actually going to be face fitted was not necessarily high in their priorities. So even before the pandemic, I was aware of the fact that face fitting was not universally carried out, and there were times when the size of the mask, the type of the mask didn't fit. That clearly was highlighted during the pandemic, and so both for the shortage, the lack of supply meant we were having to source internationally. So there were a number of different masks which would need to be face fitted for different people. So it was a huge exercise. But yes, I think facial hair, Black, Asian, minority ethnic colleagues, and a lot of women as well would have trouble with that.
In relation to Black and Asian and minority ethnic nurses and midwives, were there any other major concerns, or what were the major challenges facing them, I should say, as far as you were made aware?
So I think the real worry of what was the impact the pandemic was having on the Black, Asian, minority ethnic community in terms of, and there was a lot of uncertainty at first. This was a new virus. We weren't quite sure what was happening. And was there a greater death rate or not? And in the early days of the pandemic, it was difficult to be definitive about it. So I think there were aspects of morbidity and mortality who was going to be affected more by the virus, as well as then physically in work, not having the right protective equipment. So there was a suite of measures, which I think is why there was a response in May, Scottish Government, but my sense is we probably all did this roughly the same time. Was
May 2020?
Yes, a risk assessment. So where we issued an instruction to the NHS in Scotland that every member of staff from Black minority ethnic communities should have a conversation with their manager, which should be a supportive conversation, and within that have a risk assessment where they could talk to them about, did they have any other predisposing conditions? How did they feel about being, whether they were on the front line or not, and did they want to be redeployed? Did they have the right level of PPE or not?
In your witness statement, you set out the chronology of changes to various bits of guidance, and essentially by April 2022, there was, I think, a letter issued setting out responsibility for ensuring staff were given access to FFP3 masks based on their personal preference, and not in response to a risk assessment or IPC guidance, but if they wanted it to make them feel safer at work. By April 2022, that was a stance that was being supported by the government. What do you think about that having been brought in earlier, and should it have been?
So that, of course, was after my time as
I know.
CNO. I think the whole precautionary principle piece is one that is important to explore. And the IPC world were very keen to be particular. And I think it's important to say and describe what PPE is appropriate for keeping people safe. So I think you do need a standard, and you do need to have that rigorously implemented. If people start wearing different types of PPE, whether it's higher or lower protection, there are a number of factors. It can wane public confidence. It can cause difficulties. But I see now, it's in the National Infection Prevention Control Manual Act, when I was refreshing to come here, I see that last month, under transmission-based precautions, there's work going on, which is looking at the definition of aerosol droplet and contact. And the problem I think we had was it was very linear, and it was either FRSM or FFP3. People were, in a way, defending their corners rather than trying to find the best possible solution. And because of that, I think we've been blinkered. Now, there may or may not be unintended consequences of wearing FFP3. For instance, there's an increased level of carbon dioxide within the wearer's blood. We don't know. But now, if you're working in high consequence infectious disease, such as an intensive care where they're wearing aerosol generating procedures, then these staff were wearing FFP3 for 12 hours.
Yeah.
So I think it's something we would want to be exploring anyway. And I think, given where Gregor and I were in May of 2020 saying, if you're carrying out CPR and you want to wear an FFP3, then wear it. I think I would have wanted to have at least the dialogue. So one of the difficulties of being out with the healthcare system now is I miss having colleagues to talk these things through with. And the unintended consequences of having that, more on the health and well-being of the workforce who's wearing it, because if the employer is saying you may wear FFP3, then we need to be aware of the risks that would entail for the member of staff. So that's a long answer to say, on balance, I think an earlier discussion would have been helpful.
Well, it will resonate with evidence we've heard that Her Ladyship's been hearing now for the last few days. Can I deal with some topics very briefly, I'm afraid? And I mean no disrespect to you for the lack of time that we've been able to afford you today. Inspections. Yes. They, I think, were stopped initially in Scotland, and you asked them to be reinstated. I think it was on the 30th of May 2020. You reinstated what's called a combined safety and cleanliness inspection and an older people acute hospital inspection. Why were you asking for them to be reinstated, and what were you expecting them to try and ensure didn't happen?
So part of the CNRG work influenced me to think through how can we keep our vulnerable people as safe as possible. And therefore we stopped the inspections so that we weren't intruding into difficult times delivering care. We wanted to redeploy clinicians who were involved in inspections, and we stopped them in March. So I was concerned about nosocomial infection. Our inspections, I think, signal and flag up some very helpful areas for improvement, and therefore the programme of work that I agreed to was looking at settings where our more vulnerable patients would be. So community hospital, older people's hospitals, and the inspections that we had there certainly highlighted areas where practice could improve and reduce nosocomial infection.
Different topic, DNACPRs. In your time as Chief Nursing Officer, did you become aware of any instances of inappropriate use of DNACPRs or blanket use of DNACPRs? So
there was anecdotal evidence of GPs writing to, going into care homes and saying, well, we'll have a DNACPR. Now, anticipatory care planning is important, probably for all of us in this room, never mind older people as they get near the end of their life. So it is something that should be done, but done sensitively and done in partnership with that person and in partnership with the families. So a letter, I think, went out from the CMO in March, and that, I think, caused distress. All it said was make sure your ACPs were in place. It didn't say anything else. And out of that, we developed what is in my statement, Care Home Professional Advisory Group, where we set up a group that was co-chaired by my DCNO and one of the senior medical staff in CMO's directorate. In that, we had patients' representatives, we had social work, social care, we had the chief executive of a social care organisation there, so that we could develop comprehensive guidance for social care. So I'm aware anecdotally, under no circumstances should it ever have happened, and I think we put mechanisms in place in Scotland to prevent that from happening.
I think during your time in post, you said you were not aware of any work specifically undertaken to support nursing and midwifery staff with long COVID. That's clearly an impact on nurses and midwives. can you summarise from your perspective the impact of the pandemic on the nursing and midwifery profession in Scotland?
So going into the pandemic, we had been strengthening the nursing workforce. We had been increasing the nursing workforce. We'd been increasing undergraduate nurse places. We had been investing in GP nursing workforce, over 200 additional school nurses. So going into the pandemic, and we also had developed legislation which was set in a statutory footing the number of nurses in a ward or department, and along with a well-being requirement for employers to make sure that they were measuring and supporting well-being of the workforce. The pandemic was relentless, and it's affected probably every single person in society, but I think that the nursing workforce, and I'm incredibly grateful to them all who stepped forwards, has had a real impact. Some have been exhausted, others have been rejuvenated and found new areas that they want to work in. But I think having the right number of nurses, we did have a wellbeing hub, so we invested in the May of 2020, having wide support mechanisms for nurses. In fact, we also, for all staff, National Education Scotland also have now are recovering from the pandemic, so they have a wellbeing section on their website which is to support health and wellbeing of nurses. And my daughter was one of the student nurses who was deployed to the front line, so I was well aware of the impact that had on the whole workforce. So I had briefings every day of what was happening and the devastation it had caused, the death that they saw that they should never have seen, and the work that people have done. And I think as a society we need to be incredibly grateful. But I'm confident and hopeful that the nursing workforce will move on and be stronger as a consequence of this.
Well, with that sense of hope, can I ask you finally this, please? Aside from joining the call for better testing and greater testing capacity in the event of a future pandemic, do you have any other recommendation you would make to Her Ladyship that would really practically, you think, help the response and help nursing and midwives in Scotland? I think capacity, with surge capacity, is going to be really important, because I think we were caught in the hop in terms of we needed to cancel, and you would cancel with a new virus circulating. You're going to cancel elective work until you see how the virus behaves. But I think making sure you have enough capacity in the workforce. The nursing workforce is iller and have more chronic conditions than the population in general. So I think looking at the health of the whole health workforce, but also having physical capacity, physical space and physical capacity, so that you have surge capacity and you can move patients. You don't need to move patients for space, that actually you have a sufficiency of space to care for patients. And just one other, I think, small thing. We had retire and return gave us more capacity for nurses when we had that within the pandemic. But at that age, the normal pension age was 60, and nurses could retire at 55 without actuarial reduction. The next pandemic, the normal pension age is going to be at least 65. So we will not be able to, I don't think, rely on nurses returning the way we did this time. And I think that's where a lot of our additional workforce came from, rather than the temporary register. Understood.
So.
My lady, those are all the questions I have. I know there are some questions from core participants. Is there anything your ladyship wishes to
No,
ask?
thank you very much. Ms Mitchell, that away.
Okay.
And I do give permission for you to swap the question, Ms Mitchell,
I'm
in case there was any confusion. I think
I'm obliged, my lady, that's helpful. I appear as instructed by Amar Anwar and Company on behalf of the Scottish COVID bereaved, and there are just a short number of questions that I would like to ask you about. My learned friend counsel to the inquiry has already taken you to paragraph 35 about the face mask timeline, and we saw from that in June 2020 there was a wider use of face masks. You have also commented in your evidence about noticing after a few weeks that there was gaps in the expertise that you might need, including what was happening internationally. And I want to ask you quite a simple question, really, about face masks and healthcare. when we were watching the experience of healthcare workers abroad and the unrolling of COVID, we saw in those healthcare settings in China and in South Korea, where they had dealt with SARS and MERS, we saw in those healthcare settings the use of face masks from the start. And I suppose my question is, given that we didn't know what was the method of transmission that was most likely, ought a protective or preventative approach have been used and a decision been taken, we should use masks immediately until we know the methods of transmission? Could we have learnt from watching your colleagues abroad and implementing that as a precautionary principle?
Ms Mitchell, I've already, I think, said to Ms Carey, I think one of the difficulties of being out of the health workforce is I don't have colleagues with whom I can have a meaningful discussion who could perhaps caution me or about some of my thoughts. But the whole precautionary principle of going in at a higher level of protection would make sense to me, having looked back on what we had. I think the view was it was droplet transmission, so I think we very quickly came to a view. I think throughout the pandemic we've looked further. So I think
Sorry, if I may stop you, we understand the progression that was made. It was really whether or not it would have been a good idea to, at a very early stage, to have some ability to look internationally, to speak to colleagues across the various different countries where they had already experienced respiratory problems, and to have that expertise right from the very start and implement it.
So, Ms Mitchell, I do think so. I think our NHS are high and the IPC cell would say that they have looked internationally, but I do think some of the countries who've experienced pandemics in a different way from us have the wisdom that we should perhaps be learning from.
I'm obliged. Moving on, can I ask you, you explained what your area of expertise is and then when you took guidance from others, did you understand, having received guidance or advice, that transmission routes, droplets or aerosols, rarely function in isolation, i.e. where you have one, you will have to a degree another? And if so, if you understood that to be the case, did you report or advise the need for multi-intervention approach? And if so, to whom?
So the advice I was given was it was droplet, and I don't think for me the question, so the aerosol piece would be coming from where aerosol generating procedures were carried out rather than routine day-to-day areas where they were not carried out. So it was not in my conscious level that the mixed mode, which I think I talked about the NIPCM and the work that's going on just now, which I would welcome to make it clearer what's happening. So at no time was I of the view that there was aerosol contamination whereby staff needed to have FFP3 protection, and I took no action.
So can I just be clear about that? Are you saying essentially that what you were thinking was this is a droplet route, and therefore you weren't really considering the issue of aerosols unless it related to the carrying out of something that would produce aerosols per se?
That was the advice I received.
Moving on to another question which my lady is granted authority for. Earlier on in your evidence, you were talking about PPE, and you said that when talking about PPE, you indicated that you were having a shortage, and then you corrected yourself and said the lack of supply. And I want to ask you a little bit about that, in particular your comment at paragraph 135 of your statement. I don't need that brought up, but it said, neither I nor my directorate were aware of any shortages in PPE or RPE for nursing and midwifery staff. but we're aware anecdotally of issues in supplies not being easily available to staff in some instances. Now, I just sort of want to break that down, because from the evidence that we have heard from various bodies, and indeed I think a comment my lady made to Jean Freeman when she gave her evidence earlier on about shortage in supply, it might come as a surprise that people hear you say that neither you nor your directorate were aware of any shortages. Are we really talking about the difference in emphasis and language? If there were issues of supplies not being easily available, presumably the people on the ground floor would see that as a shortage.
So I probably haven't been clear enough, and the language choice of my statement, I think, could have been better. My understanding is, if I maybe talk, I don't know if I'm allowed, my lady, to talk about social care separately, because
I'd rather you.
okay, if we talk, that's fine. If we talk about the health system, my understanding that every single person who needed an apron, a mask, a pair of gloves, a gown, got one, and there was a heroic effort from managers moving supply from ward to ward, sometimes from hospital to hospital. So that my understanding is that everyone had the PPE that they needed, but it was complex and challenging. And when I remember speaking to one of the nurse directors about, is there enough? He said, there is, but there's a palpable sense of relief when a new supply comes into the hospital.
I think you've mentioned that in your statement. Did you speak to people who were using PPE on the nursing floor and ask them if they had enough PPE?
So I didn't. We relied on our twice weekly meetings with the Health Workforce Directorate and the trade unions and the Royal Colleges to brief us on what was happening with PPE. And I think there's no doubt in the early days that the supply was not as good as it should have been, and it did cause anxiety. And because in my mind, not just clinicians, anyone who needs it should be able to put their hand out, get a face mask or a gown and put it on, and not have to worry about next time they go back to that, will there be one there? So there's no doubt early on in the pandemic, we would have been much better to have a better supply of PPE. There was one, so when you're asking me if I knew, that we had a system in Scotland. There was a single point of contact and there was a Scottish Government email. And one of my colleagues emailed me to say, Fiona, I have this email. I wouldn't normally bother you with it. We'll deal with it. But because of what it said, I wanted you to know. And someone had emailed to say, I live near Fiona McQueen. I'm not getting enough PPE. And if you don't sort it, I'm going to go and knock her door. So they wanted me to know that. And they said, but they will sort it. I then spoke to the nurse director and she said that they had more than enough PPE. So I don't want to say nobody ever alerted me to it or everyone said there was plenty, because that wasn't always the case. But I was aware of anecdotal evidence, but it's my understanding that everyone who needed it got it. And once we were a few months in, there was a plentiful supply.
My lady, I would of course like to ask more questions, but that noise was my colleague setting the timer for me to tell me that my time was up.
I did wonder if somebody was giving you a warning.
Albeit that I think there are many more questions that I would like to ask.
I think Mr Weatherby also may have some questions on this.
I'm
issue
obliged.
Too. Thank you, Ms Mitchell. Mr Weatherby.
Thank you. Can I just pick up then where Ms Mitchell left off? I asked questions on behalf of the COVID Bereaved Families for Justice UK group. And again, picking up on PPE. We heard evidence yesterday from the Scottish TUC of really acute shortages of PPE in the early stages. Now, you were represented on what was called the Workforce Senior Leadership Group, yes, weren't you? And that's a group which brought together senior leadership from the NHS Scotland, the trade unions, professional bodies and health and social care partners. Were you aware through that group, presumably whose one of its roles was this kind of liaison, were you aware in the early stages through that group of concerns about really acute shortages of PPE?
Yes, I was.
Yeah.
But as I've outlined to Ms Mitchell, so yes, I understand there was
Right.
a shortage, but my understanding is that everyone who
Right.
needed it got PPE.
And were you aware of shortages in hospitals, for example, the Glasgow Royal Infirmary, where the inquiry has evidence that it was running low of FFP3 masks in March of 2020? Were you aware of hospitals running short of masks and PPE at that stage?
Yes, so my understanding is, so before the pandemic came, that anyone who needed PPE and a supply of PPE did not have to think twice about going to the supply cupboard and taking it and using it. But once we increased the amount of PPE people had to wear,
Yeah.
then stocks diminished. And at one time, for gowns, I think there was less than a full day's supply within Scotland.
Well, that's where I was going to head next. My lady, there's a crossed wire, I think, about my next
I'll just
question.
have it put up on screen, Mr.
Yeah.
Wynne.
It's a question.
Time of day.
Thank you. It'll be as quick as I can. INQ 000108737, and it's page 12, please. I think this, just while it's being put up, this illustrates the point that I think you were just about to make. Could we highlight the graph, please, at the top? Now, this is a report from Audit Scotland, a government report, and it sets out various pieces of PPE, and it's between April 2020 and May 2021, and the levels. And just from a brief glance at that, it appears that at the start of April, the levels of PPE were almost out, putting it briefly. Would you agree with that?
Yes.
Yeah, and were you aware of that at the time?
Yes.
Okay, and just very briefly indeed, what actions did you personally take to resolve those issues, if any?
So PPE was not, in terms of the supply of it, was the responsibility of National Shared Services, and it.
Right.
However, that did not mean to say I did not have anything to do with it. So my DCNO was on these workforce meetings, and she would feed back to me. We would be assured by our colleagues, policy colleagues who were overseeing it, that they were doing as much as they possibly could to do that.
So effectively you escalated it and you were reassured?
I think I would go farther than reassure. I think I was assured. So evidence was given in terms of, and of course by this time, there was an international demand. So
Yes.
our suppliers were struggling to supply us. We needed to get PPE from different areas across the world, and that in itself was tricky. So although we thought we maybe have a 2-day supply and we know we're going to get 4 weeks supply coming in to Prestwick Airport from China, we until it was actually into us and through customs, we didn't know. Right.
And it just, again, in one sentence, if you can, is there a lesson here moving forward for the next emergency of this nature which will occur?
For sure. I think that whole, the management of PPE, so the rotation of stock, how much you have, looking at best and worst case scenarios, then I think there's absolutely no doubt that that is one of the key areas that needs to be addressed.
Thank you.
Subject to funding.
Okay. I've got a second topic, but I think you've probably dealt with most of it, so I'll be very brief indeed. You say in your statement that the Scottish Government's specific role was limited to the general promotion of NHS Scotland as a potential employment opportunity for temporary registrants. And my question was going to be why you said that. Is it right that you say that it was limited because of your earlier evidence that in fact you didn't think the temporary registrants were in fact necessary?
So if I may take slightly more than one sentence to answer you. I think at the beginning of the pandemic, we didn't know. In fact, I thought we would have been much more overwhelmed than we were. We were looking at pictures of Italy and patients lying on ED floors, nurses becoming incredibly ill at work. So we didn't know what we were going to get, and we didn't know whether or not. So we needed to open all avenues so that we would have that supply. I think there are ways we could better utilise temporary registrants, I think, if we had a better system. Now, one of the things we did put in place from about May was we had a calculator of workload right across health and social care, so that we knew what the demand was and we knew whether or not there was
Yes.
a demand for workforce.
Okay.
And I think we probably could have done more to help the temporary registrants into perhaps social
Yes.
care or some other place that was struggling.
And you, my last point, you refer later to further preparatory work that might have been done. Does that relate to the point you're just making in terms of how you could arrange it so that temporary registrants could be brought onboarded and used appropriately?
I think most definitely, as well as looking at surge capacity and how we can keep, practitioners who are not working, contemporaneous in their practice.
And that's perhaps something that should be looked at going forward.
Definitely.
Thank you very much. Thank you, my lady.
Thank you, Mr. Worthby. Very grateful. Mr. Wagner?
Yes, I'm all the way over here. Hello. My name is Adam Wagner, and I ask questions on behalf of 13 pregnancy, baby, and parenting organisations. I've got two topics to ask you about. The first is about guidance in neonatal care. In November 2020, the Scottish Government added a line to the neonatal care guidance which said this: parents should be offered opportunities to remove face masks where it's safe to do so, to encourage bonding and support skin-to-skin and kangaroo care. And just to pick up on those final two words, is it right to say kangaroo care is a method of holding your baby to your bare chest, to allowing for skin-to-skin contact?
Skin to skin. So the baby would be bare and you would be bare.
Yeah. Were you involved in the changing of that guidance?
So I had another Deputy Chief Nursing Officer who was the Chief Midwifery Officer, and she would have developed that guidance along with the Director of Children and Families Directorate.
And do you have any knowledge of why the Scottish Government decided to modify the guidance in that way and add in that extra reference to skin-to-skin care?
So no, I don't. But my view is skin-to-skin care is an evidence-based intervention that supports physical well-being of a neonate as well as the emotional health of the parent.
Yeah, and so that would be why that exception was made to the mask wearing, that they could take their mask off, because skin care was so important.
So it's so important. And by that time, we would have seen how the virus was operating. We would have been able to take, on balance, proportionate risks that we were not prepared to take earlier on in the pandemic.
Yeah. So on balance, proportionate risks relating to the mask wearing versus the benefits of skin-to-skin care. The second area I wanted to ask you about is the wider restrictions that were placed on maternity services. And I appreciate you said that there was that you had a deputy who was responsible for that care, but may I ask you just a couple of questions about that overall point, because you do refer to it in your statement. So just by way of context, there's been a number of reports since the very early stages of the pandemic relating to the impact of IPC, infection prevention and control restrictions, on maternity services. Are you aware that, according to a 2022 report, perinatal depression, that's depression around maternity and birth, and anxiety almost doubled during COVID-19?
Yes.
You are. And are you aware of the statistic that's in the same report, that the rates of depression and anxiety amongst women who gave birth during COVID-19 were as high as 61%?
So I wouldn't have been able to give you the statistic, but I knew it was high.
Yeah. And then secondly, are you aware of there was an Embrace rapid report published in August 2020 relating to maternity services?
No, but I may know the topic if you remind me.
One of the findings that the report made. So it looked at March to May 2020, and it was published in August of 2020. And it found that 4 women who were pregnant or had recently given birth had died by suicide during that 3-month period. And the authors found that changes to the service provision as a direct consequence of the pandemic meant that women were not able to access appropriate mental health care. And it found that the receipt of the specialist care they needed may have prevented their deaths. Have you heard about those kind of issues arising?
I've heard about those kind of issues, not necessarily associated with maternity, but with wider societal issues, yes, tragically.
And then thirdly, there was a study in October 2021 that concluded the re-establishment of face-to-face parenting support groups appeared to be imperative to postnatal emotional well-being, and recommended the prioritisation of essential face-to-face healthcare visitation in the immediate postnatal period. Now, you may not be aware of the report, but would you agree with the sort of sentiment of that?
Yes.
So, in that context, I just want to ask you about your statement at paragraph 208, and I don't need to go to have it up on the screen, but you say there, whilst we recognise the impact the virus had on the more vulnerable in society, I wonder if we could have done more during the pandemic to support such groups. And you say, with hindsight, a number of measures may have been beneficial, changing restrictions to support new mothers to receive additional in-person support from family and friends. So with hindsight, can you give a bit of detail about what kinds of changes you would have made for new mothers?
So I'm going to repeat I have been out of healthcare for over 3 years, and therefore I don't have the benefit of the wisdom of having colleagues, but it's my understanding that a new mother could not have visitors. So I think being able to have your mum or your sister or a close friend or someone else coming in to help and support you would have been beneficial. So I think looking, and that, if we look at visiting in maternity hospitals, the real challenge there is if somebody is looking for additional support, then the balance is people who come in may have been bringing COVID, and then there would have been nosocomial infection right across the unit. So the balance there is someone's benefit could be harming someone else. Once pregnant women are home with their babies, or in the lead up to birth, when they're in their own house, then they can make their own decisions and take their own risks about the balance of having emotional support for their well-being versus the risk of COVID. And of course, they could then talk to whoever was providing them with that support and know that their behaviour was keeping them safe without COVID. So I think there are ways that we could have learned for how we could bubble bigger groups together to provide emotional support, or provided with social distancing classes or supports, because I know that in the postnatal period, if it had been, although you don't have to have a toddler to go to toddlers groups, you can have a brand new baby. There are many informal ways that people in society have support, and new mothers have there as well. So I think working with women to find out what was most distressing for them, and I think we know, but working to see what we could do, I think would be important, so that we know for the next pandemic, and it needs to be rehearsed and looked over, at ways we can mitigate and prevent some of the tragedies that have happened as a consequence of this pandemic.
I'm afraid you're going to have to leave it there, Mr. Wagner. Sorry. I think I've stretched the stenographer's patience to the limit today. Thank you very much indeed, Ms. McQueen. I'm really grateful to you. I hope your daughter didn't get put off nursing, did she?
No, she is thriving. Thank you.
Wonderful. Well, I'm sure it's a proud family tradition now. So thank you very much for your help. I'm really grateful.
Thank you, my lady.
10 o'clock tomorrow.
All rise.